IMV Imaging, ultrasound designed by veterinarians for veterinarians. At IMV Imaging, we provide you with the best imaging equipment and technology, creating confidence in your clinical diagnosis. We don't just sell ultrasound. We build long-term relationships to support you clinically, technically, and with any other challenges that come your way. We understand in your career, you never stop learning. As a doctor of veterinary medicine, your career is enriched by education. With IMV Imaging, you can build on your knowledge with our online resources, which include webinars, case studies, quick guides, and so much more. All of our devices and products are advanced successfully by implementing ideas inspired by the needs of our customers, veterinarians. With over 35 years of experience in designing and manufacturing veterinary ultrasound equipment, IMV Imaging is dedicated to supporting you and your equipment. Most ultrasound scanners are sold through dealers or modified from a human scanner to suit veterinary needs. At IMV Imaging, we manufacture our scanners specifically for and sell directly to you to save you money without sacrificing quality or service.
Hello, everyone, and welcome to Abdominal Radiology Review, Seeing the Hidden Stuff. My name is Amy Newfield. I'm a VTS in Emergency Critical Care here in Massachusetts, so it's cold. I would much rather be with you guys in person. I'm so sorry that we're not in person, but I'm here, and we're going to have a lot of fun. So my email address is at the bottom there. I am a fast talker. I'm sorry, and as the day goes on, I don't slow down, so apologies. But the good news is, you can check out the lecture notes and review it that way, or just reach out to me if you ever have any questions. All right, so why do we care about understanding what we're actually seeing? Because the technician is the first person to view the patient's radiographs, and we want to review the radiographs twice. The first is going to be for the technique, and the second, obviously, for what's going on with the animal. Everybody wants to know what's going on. I started doing this lecture series because I found that, I'll give you a great example. Technician held up a film. Oh, I said that like I'm so old because I am so old. Held up a film. This was before digital films. So held up a film onto a light box. Those are the days. And she exclaimed that she could see the pancreas. And as you are about to learn, you cannot see the pancreas on film. And it was from that moment forward that I decided technicians really are interested in seeing what, understanding what they're seeing on film, but also it's pretty important. So that's why I started doing this lecture series. All right. So most abdominal radiographs need to follow up with diagnostics, and that can be very frustrating for the pet owner because a lot of times you're going to take an x-ray and you're going to find nothing. And immediately the owner is going to say, oh, so he's fine. No, he could still have cancer. He could still have a foreign body. He could still have something going on. And so it gets very frustrating for owners because they just spent the money on an x-ray and you found nothing. So therefore their pet must be fine. But there's plenty of other abdominal tests out there: ultrasound, endoscopy, contrast studies, cystography, and urography. And so we're just going to talk a little bit about proper positioning because, as you will be able to appreciate, proper positioning is really key in really finding those subtle details that cause the diagnosis of an animal or not. So as far as lateral, it can be right or left. Most veterinarians and technicians coming out of school are being taught to take right lateral radiographs. It doesn't matter which way you decide to do, but be consistent in your hospital, because inevitably that marker gets kicked out of the view and then everyone's like, what view is it? If we all take a right lateral radiograph every single time, we know it's going to be right lateral. Ventral dorsal is preferred over DV. In fact, to be perfectly honest, my boarded radiologists say there's really no indication to ever take a dorsal ventral view because the abdominal contents are obscured by the spine itself. Sedation might be necessary. These animals might be in pain. They might have something going on where you might need to sedate them so you can stretch their legs out. In terms of lateral positioning, you want to pull the legs back caudally. Now, be careful in our senior animals. We want to make sure that they're pain-free, obviously. And this is where, if you're really struggling, think about drugs. There's lots of happy drugs out there. And you want to collimate to include the entire diaphragm down to the coxofemoral joints. Now, for a lot of us, when we're taking films of Great Danes, for example, we're going to have to take multiple sets. You're going to take a cranial, you're going to move down maybe to the middle, and even take a caudal. So our plates are simply not that big. You're going to need to shoot multiple times to get the entire abdomen in there. Now, male dogs and cats that have urethral problems, you need to include the entire pelvis and rectum. And in fact, sometimes you might want to actually pull the legs cranial so that you can see that urethra coming around the rectal area. This is a beautiful radiograph. So we've seen the diaphragm, the full diaphragm. We didn't cut any part of it off. And you can see the coxofemoral joints, aka the hip joints. This is really important. This is the whole abdomen. If you fail to get any part of this abdomen in there, you could miss something. For example, if you cut off part of the diaphragm, you're now missing part of the stomach and the liver. Or if you cut off the coxofemoral joints, you could be missing part of the bladder. So you want to get all of this, and don't be afraid to take multiple films if the animal's too big to fit on one. So I developed this acronym just sort of to teach my own team about always looking for these areas. So whenever you evaluate a film, you always want to evaluate a film the same way every single time. And in my head, I came up with this acronym PURGE, and it stands for peritoneal space, urogenital system, reproductive system, gastrointestinal system, and extra-abdominal area. So we're going to start with the biggest one, the G of that group, which is gastrointestinal system. So what is in the gastrointestinal system? It includes the stomach, the spleen, the small and large intestines, the liver, and the pancreas. Now, you already know a normal pancreas cannot be visualized on radiographs. So we're not even going to talk about the pancreas, but it really was the caveat for me starting this lecture series, because I was like, no, you can't see a pancreas. What you're actually seeing is the spleen. And so again, normal pancreas, you're never going to visualize it. So we're not even talking about it. All right. So here's what we're looking at. And don't worry, I'm going to break down every single one of these little areas for you so that you get a good appreciation, so that when you go back to your hospitals, you can go, that's what that is. I know. So the stomach kind of in the, left-hand side, the spleen, it sits on the bottom, and then you have your small and large intestines. Let's talk about the stomach, okay? So there's 4 regions of the stomach. You have your cardia. This is the part that connects the esophagus to the stomach through the esophageal hiatus. Your fundus and your body. The fundus is a little bigger than the body. And then the pylorus empties into the small intestines. Now, you can actually see parts of the stomach on radiograph, and I'm going to demonstrate that. Now, in terms of the position of the stomach, the spleen is attached to the greater curvature of the stomach. So we have to remember that where the stomach goes, the spleen will follow. Where is this important? In the case of bloat, right? So when the stomach twists, so the spleen will go with it. On a right lateral film, a pylorus will be down, and it may resemble a ball. This is easily mistaken for a mass. Now, I work in a specialty-only hospital, and so we get a lot of referrals in from general practice. And frequently, a couple times a year, we're going to get a dog in. It's usually always a dog where the owner's crying, going, they said he has a tumor in his abdomen. And it's not a tumor. It turns out it's a pylorus. So, and don't worry, I've got lots of films coming up to show you. On a left lateral film, the pylorus actually will be up and it will be gas-filled. So here's Jack, a golden retriever, 7-year-old male neutered. It came in for vomiting and anorexia for the last 24 hours, had diarrhea for the last 12 of those hours. On physical exam, fairly non-remarkable. Actually looks pretty good, all things considered. And so this is one of those examples where I just said to you, this dog was actually referred in for a stomach tumor. And so we take a look, the liver, that's that little pointed thing down at the bottom. The spleen, as you can see, I pointed that out, small intestines, the stomach, that round thing is what that dog got actually referred to, and it's the pylorus. There's just obviously not emptying all the way. And when you think about a dog who hasn't eaten 24 hours and we look at the stomach, there's obviously some food and material in there. And so we just basically sent the dog home on sub-Q fluids and monitoring, and the dog was fine. On ventral dorsal, and I have films for you to show you, the stomach will lie perpendicular to the spine and the pylorus will be near the right body wall. So this is where we can kind of do a deeper dive into parts of the stomach. Certain diseases like hepatomegaly can cause the stomach to become displaced from its normal position. So we take a look, this film is obviously a little crooked, but on your right-hand side, which is the pet's left-hand side. So remember, when you're looking at a film, the animal is like that, right? So it's backwards. So we want to make sure that my right is going to be the pet's left. Okay. So, and then obviously my left is the pet's right. So on my right side, that's the fundus in the body. Remember, I told you we can break down parts of the actual stomach. On your left side, aka the animal's right side, you can actually appreciate the pylorus, and it's filtering into the duodenum. So that's pretty cool. So we can appreciate that as well. So let's talk about diseases of the stomach, those that can be visualized on radiograph, because knowing that there's plenty of diseases out there that we take an x-ray, again, the owner goes, well, then he's normal. No, he might still have cancer. I can't see it sometimes on radiograph. So gastric foreign bodies is probably one of the most common ones. It's difficult to visualize unless they are actually radio opaque. So we might want to take multiple views. And so we might not just want to take a right lateral film. We also might want to flip the dog or cat and take a left lateral view, because that ingesta will move in a way that we can then visualize that foreign body. Ultrasound and endoscopy may also help to diagnose a gastric foreign body. GDV is obviously very common. So we can have just gastric distension. This is where stomach can be retained. It can retain air, but it retains in the normal position. It doesn't actually twist on itself, which is really key. So you can get just kind of gastric distension, but a true GDV is where it flips on itself. It's diagnostic if we take to diagnose a GDV on a right lateral radiograph. So when we have a bloat candidate that comes into the hospital, stabilize first. That's always important. And then go for films, right? Everybody wants to do films first. That's not the right answer. So we stabilize the emergency first, then we go take films. The only film that you really need is the right lateral radiograph in order to diagnose GDV. And I've seen VDs taken, DVs taken, left lateral taken. Just the right lateral one is diagnostic. Ultimately, during a GDV, the fundus will shift and lie against the ventral abdominal wall while the body shifts to the right, and the spleen, again, is attached to the stomach, so it's going to follow it. So this is a great example of a GDV. So you get this shelf or boxing glove effect. Sometimes people say it's a Popeye arm, whatever you want to call it. It's very clearly a double bubble effect, you know, so you've got a bubble on top of a bubble, and there's a line between the two bubbles. This is not bloat, okay? Look at it. There's no double bubble. There's no shelf effect. There's no Popeye arm. This is just gastric distension. Now, this particular dog still presents like in shock and could be truly having an emergency. They might even be retching, but they do not need to go to surgery. They need to be decompressed. They need to be stabilized. They're clearly in pain. We need pain medication, but we don't need to tack this animal's stomach. If we go back, we need to tack this animal's stomach. This animal needs to go to surgery. This one does not. Still two emergencies, just one is bloat and one is not. So we can also see a pyloric obstruction. So what can go wrong with the pylorus? We can have a chronic case of sort of pyloric stenosis, where it's the narrowing. So animals are having a hard time filtering contents through the pylorus. Cancer certainly can form right in the pylorus itself, or inflammation. Acute causes, we can get just a foreign body. So the foreign body has no problem coming from the esophagus and land in the stomach. But when it tries to filter through that pylorus, it gets cinched up. And then we could have a foreign body right in the pylorus, or gastric volvulus, right? So we twist the stomach and then the pylorus would become obstructed as well. And so ultimately, when we obstruct the pylorus, the stomach gets bigger because contents can't go through. This is a wire in the pylorus. And so this is very clear. You can see actually the folds. If you look at kind of to the left of that wire, you see the little rigid folds. That's the lining of the stomach. You can appreciate that on radiograph. And that's a pylorus that wire did not pass through very well. Gastric ulcers, these are pretty difficult to identify on radiograph. Usually you have to confirm them on endoscopy or ultrasound. And so a lot of times when dogs are vomiting blood or vomiting a lot, we may take them, again, for radiograph. We're not going to see anything. Owners are going to go, oh, it's a miracle, he's fine. And then we're like, no, we need to go to endoscopy or see what's going on. Especially anytime they're like vomiting blood, that's a definite, probably just go to endoscopy and see what's going on. Most commonly, they're associated with cancer, but there's plenty of benign ulcers out there. My older dog, who's no longer with me, a couple years before she passed away, started vomiting blood. She was on NSAIDs, and she had lots of gastric ulcers thanks to chronic use of NSAIDs for her arthritis. Dachshunds are actually predisposed to gastroduodenal ulcers. And then moving away from the stomach, we have obviously our small and large intestines, and we tend to evaluate them from left to right on films. Really, the position is dependent on the weight of the animal, the size of the bladder, and the size of the stomach. Now, you can usually see the cecum in dogs, but it's a little bit harder to identify it in cats. Cats like to hide a lot of things, as we know. It is C-shaped, and it lives between the L2 and L4 vertebrae. Don't worry, I've got a picture for you. But C-shaped as in cecum, easy to remember. Cecum for that C-shaped thing that you see there. Now, I can't show you through a pointer, but what I want you guys to evaluate is at the end of the last rib, that is the end of the thoracic vertebrae. And then we start with the lumbar or the L vertebrae. So look at the last rib and then start counting the lumbar vertebrae. 1, 2, 3, 4. Go straight down between 2 and 4. There's your C for cecum in dogs. It's really nice when it shows up like this. Okay, so now we know that's the junction between the small and large intestines. Here it is on a VD. And so again, look at the L2 and the L4. See that last rib? That's the last thoracic vertebrae. Start counting down. 1, 2, 3, 4. It lives a little bit, a tiny bit above 2, but it's always a good bet if you go 2 to 4 and move over to the dog's right, your left, you will usually find cecum. Small intestines. This is made up of obviously the duodenum. This is the part that filters contents from the pylorus. It is the shortest part of the small intestines, and it can be easily seen on a cranial lateral radiograph. Now, the jejunum and ileus, the ileum, they're all kind of just together, right? They're together suspended by a mesentery, and you're going to get these nondescript loops. You can't just say, oh, there's definitely a foreign body in the jejunum. That's not going to happen, but you could say that in the duodenum, depending on where you see it on radiograph. Now, diseases that we see on radiograph in the small intestines, the big one's ileus. So this is defined as a decrease or complete cessation of motility in the intestines. It appears gas-filled or fluid-filled, and the loops exceed the diameter by the ribs by 3 to 4 times. So as we know, the intestines are always contracting, they're always moving, they're always kind of mobile. And this is where, unfortunately, they stop moving and they just kind of get dilated. And it's pretty obvious on film. There's 2 types of ileus. We have our functional or mechanical. And I'm going to talk very briefly about contrast media. So I dated myself a little bit when I said we pulled up the film and we showed it on a light box. Nobody does that anymore, Amy, but that dated me a little bit. So to date me even further, before we used to have ultrasound in most of our hospitals, we did a lot of contrast media. Now, ultrasound has gotten amazingly advanced. If you're not aware, you can actually get probes and hook them up to cell phones at this point or iPads. It's crazy. So I know that a lot of general practices have ultrasound, but not all of them. So contrast media is still used, and essentially what it is it's a dye, right? You put it in the animal, you have them swallow it. Hopefully, BIPS is a great example of contrast media. The problem is that statistically it does not produce diagnostic results, and it should be reserved for when patients, when a diagnosis is very difficult and we're struggling with getting that diagnosis. We also know it's super expensive to do. So the enemas, 24-hour fasting, multiple films, sedation, and staff time. And if you have any other dinosaurs who are listening to this, and by dinosaur, I mean you've been in this profession for more than 20 years, like myself, if you are a dinosaur like me and you ever hand dipped and you had to do contrast media, you are my people. Because for those of you who are not aware of the nightmare before the digital age, this is how contrast media happened. Well, first we did enemas, then we did 24-hour fasting, lots of enemas. Then we would set up, give the animal the contrast media, rush it in. They were awake, take a film, and then dip as quick as we could and write 1 minute. Okay, and then we get the animal back in because by then it had already been 5 minutes. And we quickly take another film and we hand dip as fast as we can and we write 5 minutes. Take the animal again. All right, do it again. Now it's been 10 minutes. Super fun. Those were the days, kids. And we'd write black magic marker on the radiographs. It was so fun. Digital is so amazing. So I really love technology. But in any event, regardless, now with ultrasound, it is way more diagnostic to just do ultrasound. All right, so functional ileus. This occurs when the bowel has a vascular or a muscular abnormality, and it can occur from a variety of diseases. Like parvo does this. So if you've ever had a really sick parvo puppy and you've taken a radiograph and everything looks really dilated and their intestines just look like they're not healthy, it's probably because they have a functional ileus. Peritonitis also does this, or less commonly from mesenteric volvulus or spinal trauma. Mechanical ileus, this is a physical obstruction, foreign body or a tumor, and generally animals are painful on palpation. So we're going to take a look at Tom. He's a basset. He's male neutered and he's 6 years old. He has a history of vomiting. He gets into the trash a lot. Shocker, I know, because he's a basset hound. And he eats things off the ground. Really? I had no idea basset hounds do that. On physical exam, he has a very painful abdomen. Of course, he goes, and you're like, poor Tom, what's going on with you? But his vitals are normal. And we take a film. And this is where owners get excited, right? Because when you take a film and it looks like this, you go, oh, your dog's got something in it. And it turns out it was a rock, by the way. But we can also appreciate the ileus. So remember that the diameter of the actual intestines have to be 2 to 3 times the width of an intercostal vertebrae, or rib cage. So we take a look at that rib, see how it says 1, that's the width. We're going to take that same width and measure it up against the width of the actual intestine. So this dog is suffering from a mechanical ileus because of that rock foreign body there. Intestinal foreign body, no, kitten, don't play with the string. One of the big ones is a linear foreign body, meaning long. So it's that long foreign material, such as a string or nylons, or hair ties can be another one, whatever it is, thread and needles. Yeah, that's a bad one too. They become lodged in the stomach, and so the stomach will hold on to the foreign body, and then the foreign body gets stretched out until it's completely stretched. And it can actually act as a saw, and it can actually perforate the actual intestines. Now, what we see, and now GI, by the way, scrunchies are coming back, because I had this in here for a while. I had to take it out because people were like, what's a scrunchie, Amy? But I now know that scrunchies are making a comeback. So yeah, I mean, everything from the 1980s is coming cool again. So you're welcome. I just saw slap bracelets in a store the other day, and I was like, slap bracelets, yes. And maybe jelly bracelets. I don't know if they're back, but they are pretty cool too. So GI bunching is the scrunchy kind of look on radiographs. And this is what that looks like. So this is conclusive that this animal has a linear foreign body, because that long line has caused the stomach, or the intestines, excuse me, to bunch up on each other, and they get this wonderful scrunchy feeling that you see there. So cancers of the small and large intestine. Most common neoplasias include adenocarcinoma, lymphosarcoma, mastocytoma, and leiomyosarcoma. You've got to really obtain an ultrasound or a barium study to really diagnose the presence of a mass. Typically, you don't see it on a small intestine or a large intestines. And then intussusception. It is hard to appreciate it on radiograph. Ultrasound is the key for this one. But what you get is telescoping. And so the intestine will kind of suck into itself over and over, just like a telescope. And eventually it becomes obstructed because it gets smaller and smaller. Usually a tumor does this, or a foreign body. And then diseases of the large intestine, most common, well, technicians and assistants love this one, colonic impaction, woo, woo, right? Who doesn't like a dog or cat that's constipated? It always occurs around the holidays, particularly around Thanksgiving. One of the worst constipated dogs I've ever seen was an English Springer Spaniel who ate pretty much the entire turkey carcass. And then he was literally pooping out shards of bone and screaming about it. And all the pain medications in the world could not help this poor dog. So causes of colonic impaction: dietary indiscretion, like a turkey carcass, changes in diet, a mass for megacolon. So megacolon, my very first cat was a megacolon diabetic who then developed pancreatic cancer. I know, I have lemon pets just like you. So this is a common in older cats. It's generally idiopathic, but it can be associated with spinal or metabolic disorder. I don't mean to brag, but this is my cat's first radiograph. And yes, I hand dipped this film myself. That's how old it is. But to date, I don't know of another cat on the planet that I've ever seen that has had such bad megacolon. To put this in perspective, my cat is on the top and a normal cat's large intestine is on the bottom. So she was a stray cat that arrived at our hospital. Her name became Maddie because she was all matted and disgusting. We didn't even know if she was a boy or girl. She had fecal matter on her tushy area. And she was older. We didn't know anything about her. Shaved her down, obviously took some films, and we're like, oh my gosh. I kept hoping the megacolon would resolve. It turns out it did not. I got a lifelong of megacolon cat, but she was wonderful, and I loved every moment of her. So anyway, there you go. That's a severely megacolon cat. I'm the winner of the biggest megacolon ever. All right, so liver. This appears cranial to the stomach. It is the largest solid organ in the abdomen. On ventral dorso, the liver is fairly symmetrical in dogs. It sits a little bit more to the right to the cats. The liver lobes should be crisp and white and triangular in shape. Now, in younger animals, it may look small. I'm not too concerned because it just hasn't fully developed. The gallbladder is located in the cranial ventral portion of the liver, and you should not see it. So we're not going to talk about the gallbladder. Now, in fat animals, the liver might actually become displaced dorsally and look like it's shoving the liver upwards. There is no normal liver size. When we talk about thoracic radiology review, we're going to talk about normal heart sizes and how to measure heart sizes. But in the case of the liver, and very soon we're going to talk about the spleen too, you can't measure liver size. There is nothing that's normal. But this is a normal, healthy looking liver. So we want triangular. It should come to a nice crisp point. See that beautiful point there? And it should come back up, and it should be beautiful, mostly triangular in shape. But as far as liver abnormals that go that we can see on radiographs, very mild changes can't be detected radiographically. So we might have an increase in T-bili or ALT, but we're still going to see that, the liver looks fairly normal on radiograph. Again, frustrating for the owners because you go, oh, he's got increased liver values. Can we take some films? And then you go, oh, they look normal. And the owner goes, so he doesn't have liver cancer? I totally did not say that. I just said, it looks okay. We need more diagnostics. So prep your owners ahead of time so they don't go, what? I got to pay more money? Yes, you do. All right. So we can appreciate generalized hepatomegaly. It will result in these kind of round, blunted edges. And we can the liver can become so big that it pushes the stomach, the spleen, and the kidneys out of the way that they normally should be. So changes in liver size, hepatic lipidosis, so fatty liver syndrome causes it to be big. Steroid hepatopathy, so chronic steroid users, we will see it be big. Chronic hepatitis actually can make the liver big or small. Cancer or benign masses, really, you can't really tell where the tumor is. If you see a tumor in that area, it could be stomach, it could be liver, but it will make the liver either big or small. Cirrhosis will make the liver small, and portosystemic shunts will make the liver small. So we're going to take a look at Bowser. He's a bulldog, male neuter, 10-year-old. He has a history of ain't doing right. That's ADR. I mean, and upon investigation, the owner said, well, he's lethargic and he's anorexic. He also, shockingly, has had chronic skin issues. No way, a bulldog with chronic skin issues? Get out of town. So he's been on steroids like for the last 5 years of his life, on, off, but is currently on steroids. On physical exam, non-remarkable. And his blood work shows an increase in liver enzymes. So we go for an x-ray. Woo! So he has chronic hepatitis, and this is likely from that prolonged use of steroids. Take a look at it. See that round, blunt edge where it says liver, and see how the point is that it's not really a triangular shape. It's kind of this weird, like half moon shape, and it's very round down there. That isn't an enlarged liver. Now we take a look at Nash. He's a 10-year-old lab, male neuter. He's vomiting, anorexic, and lethargic. We take a look at his liver. Now this is an 80-pound lab. See how tiny his little wee liver is. He was diagnosed with cirrhosis of the liver, which sometimes can happen in older animals. As long as the liver's still functioning, as long as liver values are okay, we don't care, and that was the case here. But take a look at his wee little liver, right? You can also appreciate, I want you to look up towards the spine. See the C for cecum? That's pretty cool to see. All right. A spleen, in the normals of the spleen is that the appearance and location can vary greatly. It's best seen right below the cecum. Remember L2 and L4, you just go directly below the cecum, following the same L2 and L4, and you should see it on the right lateral radiograph on the abdominal floor. It's harder to view on the left lateral radiograph, which is why most people are told to take a right lateral view. On ventral dorsal, it lives between the fundus and the left kidney next to the body wall. And now in cats, they like to hide their spleen. So don't be surprised if you never see the cat's spleen. That's okay. Again, cats like to hide a whole bunch of things. And the size, again, is subjective. We don't have normal spleen size. So there's an ECG lead in there. That's that little dot. I want you to appreciate the stomach, the pylorus, the very triangular shaped liver, and then move to the right of the liver on the floor of the abdomen. Boom. I also want you to go directly above the spleen. Follow your eyes up, right above the ECG. See the little tiny C for cecum. It's not as C-shaped, but it's kind of got a little curve to it. And I want you to look for L2 to L4 vertebrae. So again, look at the last thoracic rib and then start counting 1, 2, 3, 4. And you're going to see right below 2 and 4. Boom, there's your cecum. And then keep going down. There's your spleen. That's where it should live. Now, on a radiograph view that's VD, it's a little bit harder, but I want you to look on your right, the animal's left, correct? And you're going to see it kind of shadowing there. Don't worry, I've got a little image popping up for you, so appreciate, there it is. That's your spleen, and again, still sits L2, L4, just the other way. So that's really important. Abnormals that we can appreciate with the spleen. Generalized splenomegaly results from that same round blunted edges. It can actually be completely like a basketball shape. And there's 4 reasons why we get splenomegaly. Inflammatory, or ehrlichiosis will do this, or toxoplasmosis. Hyperplasia, like hemolytic disorders, like for example, IMHA. So when we have a destruction of a lot of red blood cells, it can actually cause the spleen to get enlarged. Congestion, like splenic torsion, and torsion actually will cause the spleen. So the spleen itself can torse even though the stomach's in normal position, and it will cause the spleen to actually become C-shaped. I've only ever seen this a handful of times in my career. Barbiturates is another one. Propofol will do this, and my radiologists hate when if we've given the animal propofol and then it goes for an ultrasound. They need to know that, because otherwise on ultrasound, the spleen will look very big to them and they will mistake it for an issue that it is not. So keep that in mind. And then infiltrated diseases, certainly cancer is the big one, right? So Kramer, 10-year-old man neutered Labrador, he presented collapsed. He has a heart rate of about 200. He's panting, pale white gum color, so he's obviously in shock. And he's got blood pressure of 50 systolic. Not good. Kramer's not doing very well. We take a film, and here's what we got. First of all, we've cut off the diaphragm, right? So we can't see the liver at all. But we can see that the intestines are being pushed out of the way, and that is because of this very large splenic mass. Now, if you're going to go a little bit to the left of the splenic mass and down on the floor, you can actually see the spleen. But remember, the spleen is flat, like my hand. So it's very long and it's very flat. And in this case, part of it is okay, but then the other part has the tumor. So that's what we're seeing here. Now, look at his bladder. It's the least of his problems, but he's got a bladder stone, right? All right, so the urogenital system. So remember purge, right? We go back to that. We've done gastrointestinal, but let's now talk about urogenital. So adrenal glands, we're not going to talk about them. You can't see them. Kidneys, ureters, we can't see them. We're not going to talk about them. Urinary bladder, urethra, and prostate gland. Again, just like gastrointestinal diseases, most urogenital system diseases require further diagnostics like CT, ultrasound, urography in order to diagnose what's going on. Let's talk about the kidneys, kids. All right, so depending on the amount of material in the intestines, it might be difficult to view both kidneys. Now, where do we find the kidneys? Don't worry, I've got films for you. On location on the VD, the right kidney generally likes to hide. It's usually poorly visible, but it's supposed to live around the 13th rib near the pylorus. It's about 2 to 3 times the length of the L2 vertebrae. Now, the left kidney, usually we can see it on VD. It's located caudally to the spleen, so you got to find the spleen, and usually the kidneys around there. In the mid-abdomen, it's usually easier to see the right, and it's about 3 times the length of the L2 vertebrae. So here, if we take a look On your right, you can easily see that left kidney, right? This is on a cat. You see that weird shadowing right behind, right up against the stomach wall? That's the spleen of a cat. It's there. You can finally see one. Now, I want you to shimmy on over to your left, or the animal's right, and you see just kind of the edge of that kidney. Again, it can be a little bit harder to appreciate the right kidney because of the material. The left likes to live near the spleen. The right likes to live a little bit, I find, more towards the actual spine itself. All right, on lateral view, the right kidney is more cranial than the left. It's located dorsal into the spine. The left kidney is more pendulous. It can live wherever it wants in the abdomen, basically. And sometimes they're right on top of each other. It makes it really hard to define which is right and which is left. Okay, so here, if you remember, you've got right up to the top, right closer to the spine. That's always going to be the right kidney, and also lives closer up to the head cranially. So that first arrow on, if you go left to right, that's going to be your right kidney. That's shadowing right there. The one in the middle that's very obvious is your left kidney. And the left kidney can kind of live wherever it wants, but it's usually behind or to the right of the right kidney, I should say. And it's usually a little bit lower down. I want you to also appreciate the stomach, you know, and how it's skinny, and then it rolls into kind of that ball, which is the pylorus. I want you to appreciate to the left of the stomach, that triangle, that is the liver. And this is a cat film. I want you to appreciate that kind of right below the left kidney between an L2 and L4. If you go right down, hit the abdominal floor, you can see just a tiny little bit of the spleen. It's right there. All right, there's your right, there's your left. So what can we see on film that is a disease of the kidneys? Certainly in cats, chronic or acute kidney failure is one of the most common diseases that affect our cats. Kidneys can appear small or large or irregular shaped on radiographs, and we can appreciate renal calculi too. This is renal calculi. So if you look on from left to right, that first arrow, that's the right kidney, and then you see the left kidney right next to that, and you can appreciate the mineralization within the renal kidney itself. And so this is a confusing chart, but it's in the lecture notes. So when you have a kidney that has normal size and shape, but you're seeing elevations of BUN and creatinine, so there is some liver dysfunction, we think of things like glomerulonephritis or acute pyelonephritis. If you have a normal size kidney, but it's no longer bean shaped, it might look square or triangular. We think about things like infarcts, chronic pyelonephritis, abscesses, or polycystic renal disease. If you have a teeny tiny kidney and a regular shape, so it's still big, bean shaped, we think of hypoplasia or glomerulonephritis. If you have a small size kidney, but it's not holding its shape anymore, dysplasia or end-stage renal disease. If you have gigantic kidneys, but they still look like an actual kidney bean, we think of things like cancer, glomerulonephritis, pararenal cysts, or hydronephritis. And if they're huge and also irregular, you think about cancer, primary tumors, or hematomas. So this is obviously not normal. So I'm going to blow this up in the next one, but I want you to appreciate that right there, we've got the right and left kidney actually on top of each other. So you can appreciate that tiny little thing over what looks like basically a rectangle. That rectangle is the left kidney. The teeny tiny one that still kind of looks like a kidney bean, that's the right kidney. This is end-stage renal disease. And here you go right there. So pretty sick looking cat. And again, we can't necessarily say what's causing the renal disease. We just know that based on this film, this animal has pretty significant renal disease. The urinary bladder, so this is located in the ventral caudal abdomen. It's too difficult to view on VD, and the reason is because the spine is superimposed over it. So remember how I said I have a lot of radiologists who say there's no point to taking a VD, or a DV, excuse me, and that's because if you do dorsal ventral, you've got a huge spine. It's already hard enough to see things like a urinary bladder if you do VD, and so we're always going to shoot VD when we're taking abdominal films. Signs of the bladder disease are limited to radiographs. All you can see is that the urinary bladder is in abnormal position, it's abnormally shaped, it's abnormally sized, or it has a weird opacity. And so usually when we're looking at bladder diseases, again, contrast, cystography, or ultrasound is really going to help to diagnose it. Cystic calculi, so we've already seen an example of a bladder stone, but remember this, not all calculi are radiopaque, but those consisting of phosphate, oxalate, or silica are. And then certainly a ruptured bladder. So you no longer have a nice crisp white edge looking like a bladder. It might be ruptured or looking frayed. So here we go. Again, that's cystic calculi, the urinary calculi. These are radiopaque, so you can see them pretty easily on film. The urethra in females, it's rarely evaluated on x-ray because it's short and wide and they tend to have less issues with it. Now in males, both our dog and cat, they have these long, narrow urethra. So if we're evaluating the urethra, we have to include the rectal area because in our dogs, it comes down past the rectum area, right? Whenever we're dealing with a pet that's undergone a pelvic fracture, we definitely want to think that maybe the urethra could have torn. And so if we think that the urethra torn, we want to do contrast urography in order to really diagnose that. This is why we include the entire area of the abdomen. If we had cut this off, we would not see that this poor male dog has a stone at the end of his little willy, and that is really sad. All right, and if you look here, this is contrast urography. So we have injected a dye into the bladder and throughout the urethra. And if you look, you can see the bladder, but then I want you to look above the bladder, right, up towards the spine. You see how the contrast material is not in the urethra and it's not in the bladder. That's because there's a rupture in the urethra. And so unfortunately, this got torn. So that's what that looks like. Prostate gland, this is located at the neck of the bladder. It may be obscured by the pelvic canal. It's not normally visible, so we don't typically look for it. However, obviously, we sometimes do see it on radiographs. So always include that caudal abdomen in males. And diseases at the prostate that we can see on radiograph, most common one is prostatic enlargement. So in order to truly diagnose what's going on, we're going to have to do an ultrasound in order to confirm that prostatic disease. But usually it's benign prostate hypertrophy. That's probably number one that causes it, the BPH. Prostatitis, a bacterial infection, or cysts. Then you can get both benign or neoplastic. So we're going to take a look at Rex. He's mixed 12-year-old male intact dog. He's been straining to urinate, dribbling a little bit of blood. He has an exceptionally painful abdomen. His heart rate's 180, so he's a little bit shocky. His respiratory rate's 48, and his gum color's pink. So we take a look. Whenever in males, you get two bladders. And so if you look, obviously you can kind of see the liver and the spleen have been shoved forward. But when you look, okay, you can see the bladder. It's there. Right behind the bladder looks like another bladder. That's a prostate. Okay, so you never want to see two bladders in a male, or one of them is going to be the prostate. Now, here's the kicker to this. If you see two bladders in a female, one of them is an enlarged uterus. And don't worry, I'll get to that. So we've got two bladders. One's obviously prostate. Prostate is always behind or to the right of obviously that bladder. There we go. That's your prostate. This dog is going to present much like a male blocked cat, unfortunately. All right, so here's that same dog. And this is why normally we do not see the bladder, because the bladder will live in the pelvic bones and you can't see it. But in this case, because of the prostate, it got shoved forward. Now, I pointed out a little question mark there because we have to wonder, is that a bladder stone? A least of this dog's concerns right now, obviously, because he can't pee, but certainly keep that in mind. All right, reproductive system, so the R, right? So the female reproductive system, normal ovaries and uterus are not normally visible on radiographs. The majority of the uterus is cranial to the bladder in the mid-abdomen. It can expand. Anybody who's been pregnant knows it can expand to encompass the entire abdomen, right? The uterus is not normally visible until it gets larger than the intestinal loops. Fetal mineralization is not visible until day 42. Ultrasound is better for early detection of pregnancy, but radiographs are better for counting fetuses in our veterinary patients. How do you count fetuses? It has to be a skull attached to an anatomically correct spine. So the spine is going to be straight, not bent in half, not deformed. So obviously I work in emergency, so you can appreciate there is a puppy stuck in the birth canal. You can see the spine, and you can see the cranium. And then I want you to look at the other one where it's got the spine and the skull together. They're attached beautifully there. So and I pointed out that the one puppy is jumping on the bladder of the mom. Poor mama. The male reproductive system, here's the thing, it lies outside of the abdomen. Look at it, kids. If you want to see, you don't need to take an x-ray. You can look at it. It's right there for you to view. Retained testicles are not usually visible on radiographs. So I see a lot of general practitioners, if there's only one testicle, wanting to take a radiograph. Honestly, it's a waste of the money. Unless they're obviously diseased, it's a problem. And to be perfectly honest, retained testicles cause problems. You can have torsions, you can develop more cancers. So really, retained testicles, you just go in and find it. There's no need to take an x-ray. Just go in and search for it because you don't normally see it anyway. All right, the P of purge is peritoneal space. It has nothing to do with outer space, but this picture is cute. So peritoneal space is a thin membrane. It's divided into two layers, your parietal and your visceral. So your parietal covers the surface, the inside lining of your abdominal cavity. That's what the parietal layer is. And the visceral layer covers all of your organs. So there's a visceral layer on the spleen, on the pancreas, all of that. We don't want to see the peritoneal space. But all of our body at some point, it has obviously fluid in it. Normally, we know this because if you ever do a spay and neuter, you open up an animal, it's nice and moist and gushy in there, right? But we don't see the fluid on radiograph. If we start to get fluid buildup in the peritoneal space, then we lose detail because it contrasts out the organs. And so we can have what's called a normal loss of detail. Animals under 3 months of age or those that are emaciated will have a normal loss of detail. So tumors, masses, or peritonitis, which is the inflammation of serosal surfaces, can cause a decrease of detail. There's nothing wrong with this kitten other than that it's a kitten and it looks like a jelly blob. And so I have a love-hate relationship taking films of little wee animals that are 6, 8, 7 weeks, 10 weeks of age, because their joints aren't fused and they look like gelatinous blobs. There is nothing wrong with this kitten, but you should know you will see almost nothing unless it's a blatant foreign body. The only thing you can see in there is there's a stomach, it's got some intestines. That's it. You don't see any other organs, and that's normal. So just know that. And here's Sassy, a 20-year-old domestic long-hair female spayed. She has a history of anorexia, weight loss, lethargy, vomiting 2 times a day. This cat was a terrible physical exam, dehydrated by 12%, heart rate of 140. So she's bradycardic, meaning she is decompensating at this point. She has severe effort with a respiratory rate of 80. She has a temp of 96.2 Fahrenheit. She's pale, gum color, and a pulse ox of 65%. She has a very large mass protruding from her left side. That is a loss of detail that's not normal in an adult cat. And so all you can really appreciate is, well, just some air in the stomach and really no abdominal contents. Now, the lungs gave us a clue. There's the tumor up there. We take a film of her lateral view and see how she has even less detail than the kitten. That is because there's nothing but fluid in there. And so that's really sad for Miss Sassy. Gas formation, we all make gas. You know this. We don't have to talk about it though. Normal gas formation occurs in your fundus, your duodenum, your cecum, and your colon. You can get abnormal gas formation though in the intraperitoneal space in the penetration of abdominal wall. So dogs that might have a stick go through their abdomen, or big dog, little dog, perforation of the bowel, or ruptured mass. So you can appreciate how the gas in this animal's stomach has contrasted the organs very differently than they normally would be contrasted. And this is likely because of GI lymphoma that has spread throughout the abdomen. It's caused all this free gas that unfortunately has occurred in the peritoneal space. We can also see the disruption of the border. So remember, peritoneum should be continuous, but we can get hernias. So the hiatal and the peritoneal pericardial, we're going to talk about those in the thoracic series, but inguinal and perineal can also occur in the abdomen. So the inguinal, oh, I hate even reading this. It's when the muscle tears in your inguinal area, and you know where that is, causing the abdominal contents, usually the intestines and bladder, to exit out of the peritoneal cavity. The perineal hernia, oh, that's your region surrounding your anus and your urogenital openings, and it tears. Oh, the pain, the suffering. And then intestinal bladders come out. So we're going to take a look at Princess, a Siamese 2-year-old female spayed. She has a history of urinating inappropriately. She's got bloody urine. She's still eating and drinking, very active, indoor only, and spayed 9 months ago. This was definitely a weird case. She has a tumor in the inguinal area, and the owners brought her in because she's been peeing around the house, peeing blood all over their carpets, but she's very painful in the abdomen. I would say there's a good reason. She actually dehisced her spay incision, not a cause unknown. 9 months later, you can appreciate her bladder and her intestines coming through that area. And then the E in purge, right? So extra abdominal area. And this includes your pelvis, your spine, your abdominal muscles, and your abdominal wall. You have to look at the extra abdominal area. It is a good detector to tell you if your film is good or bad. The spine should be crisp and white. If you're seeing a lot of gray or hazy area in the spine or on the bones, maybe the animal moved or really bad exposure. You want to see the spine that's crisp and white, and the spacing between vertebrae should be equal. Now, in our older animals, dogs and cats will get spondylosis, so you can appreciate the bridging of the spine there. That's basically back arthritis, but they're going to be old and crunchy, and we want to handle them with care. So in conclusion, the ability to diagnose diseases relies heavily on the quality of the radiograph being taken. As a technician, you're the first one to get to view it, so definitely take a look and see what you think you see. And being able to identify normals from abnormals may save a patient's life. This is my beautiful dog Blitz. I always end my presentations with my own kids. One, because it's my presentation, and two, they're adorable. So who doesn't want to end this presentation with looking at my animals? My email address is up there along with my website. Definitely reach out to me. I know this is a lot of material, and I know when you look at the lecture notes, hopefully it'll jog your brain on helping you remember everything I just went through. Thank you so much for listening, and I'm happy to answer any questions. Hello, everyone. Welcome to Evans Syndrome, breaking down IMHA and ITP. Again, my name is Amy Newfield. I'm a veterinary technician specialist in emergency critical care out of the Massachusetts location of Blue Pearl. My email address is at the bottom there. And if you attended the previous lecture of mine, you know I'm a fast talker. I'm not kidding. So if you ever have any questions, just reach out to me. But the good thing is my lecture notes are very complete, because when you talk this fast, everyone will get a hand cramp if you try to write down every single slide. So instead, just focus on what I'm saying, and I promise you that the slides and the lecture notes follow along, because otherwise no one would keep up with me. So let's talk about breaking down IMHA and ITP. So just a quick introduction: immune-mediated hemolytic anemia, that's what we're going to be talking about. This is the most common cause of hemolytic anemia in dogs. And then ITP is immune-mediated thrombocytopenia. This is the most common severe thrombocytopenia in dogs. Both of these are rare in cats. If it is a cat that has either one of these, they're probably owned by a veterinary technician or veterinarian, because we are the ones who own the most diseases and the rarest animals in the world, right? Now, they can occur simultaneously, or they can occur separate from each other. When they occur together, when they occur simultaneously, that's what's called Evans syndrome. Interestingly enough, about 60% of dogs with IMHA will also experience ITP. They tend to get IMHA first and then morph into ITP. So we see a lot of Evans syndrome dog patients. By definition, it is an autoimmune disease in which the individual's antibodies attack their own red blood cells and their platelets. Essentially, we're dealing with a bad body. And it's very interesting, because obviously the body's whole job is to try to heal itself. So why does it start to attack itself? So let's break down IMHA. I love this photo. Oh my gosh, Basset Hound, so much skin, so much mouth. I don't know what is happening. I love everything about this photograph. All right, so let's break down IMHA. So there's two causes of IMHA. One, we can have primary or secondary causes. So primary, idiopathic, meaning we have no idea. So a lot of times you might not even be aware. You actually know part Latin. So idio, meaning idiot, have no idea. Pathic, meaning of of blood and nature and body. So I have no idea what's going on with the body, right? That's essentially what idiopathic means. 60 to 75% of dogs develop a primary idiopathic, I have no idea why it happened, IMHA. But we can see a secondary IMHA. So that's things like viruses, bacteria, or parasites. That we can see vaccine-induced or drug-induced too. So for example, cephalosporins and sulfotrim, for example, have been indicated in causing a secondary IMHA. So that's really important. In both forms, though, no matter what causes the IMHA, the red blood cells are destroyed because antibodies are produced against the red blood cell membrane of the antigen. It's very interesting because there's been not necessarily any foreign introduction. Just all of a sudden, the body looks at itself and says, I don't know you. Who are you, red blood cell? And the red blood cell says, well, I live here. I have been created out of the bone marrow. I'm very much a part of this body. And the body says, no, you're not. You're an invader, and just starts attacking the red blood cells. So let's kind of do a quick review. So antigen is the foreign substance or the insult. In this case, the antigen is considered to be the red blood cell. The body does not recognize that it is the same thing it's been seeing for its entire life. It's like it has amnesia, wakes up and goes, I don't know who you are. All right, so the antigen is the foreign substance or the insult. The antibody is a specialized immune protein which is produced in response to antigen in the body, and it works to destroy the antigen. So in this case, the body just goes, I don't know who you are. I'm going to murder you, red blood cell. So much is really unknown. We don't really all of a sudden understand why there's this inappropriate antibody production occurring. Unfortunately, antibodies are produced in response to purposefully trying to kill the red blood cell. The end result is that the antibodies overwhelm the red blood cells. They actually attach themselves to the red blood cell, and they cause the red blood cell to become damaged. And then water starts to leak into the cytoplasm, causing the red blood cells to swell up and actually explode. And so we see this attack of the antibodies coming in. Antibodies will actually clump onto red blood cells, and they cause the red blood cells to actually clump together. They're really sticky, and this causes agglutination. And don't worry, we're going to talk about agglutinating slides, right? These clumped red blood cells are going to slow down the passage of normal red blood cells, and this can cause an increased rate of extrahemolysis. So think about it. If you had a red blood cell attached to another red blood cell, attached to another red blood cell, and they're all grouping together because the antibodies are sticky and it's kind of like glue, now you've kind of got a clot, right? That's what that looks like. And now normal red blood cells are coming along, and what happens to them, you think? They get stuck to those other sick red blood cells, and they unfortunately die. So this is why we see when it starts to happen, it very quickly spirals out of control. Now, most of the attack occurs on the mature red blood cells. The mature red blood cells are the ones already filtering around in the actual bloodstream, and regeneration of red blood cells is usually pretty apparent. However, every so often, we can see the antibodies go into the bone marrow and start to attack the precursors of the red blood cells. And so now we start to see the attack on the immature, on the baby red blood cells. And this is where we get non-regenerative IMHA. And so again, we don't know what happens. It's like the body has an amnesia. It wakes up, goes, I don't know who you are. You should not be here. And the red blood cell's like, what? I've always been here. I'm part of you. Please don't kill me. And then as these antibodies are forming and circulating around and attacking red blood cell, one of them looks into the bone marrow and goes, guys, they're made in here. They're made in here. We've got to attack them. And so now all of a sudden, these antibodies start to swarm in the bone marrow. Obviously, that's when the prognosis gets much worse. So who are the lucky, unfortunate ones who get IMHA? Middle-aged dogs are more prone. So spayed females are more likely to develop secondary IMHA. So they seem to have more vaccine-induced or cephalosporin or sulfotrim-induced secondary IMHA. We have found evidence of genetic predisposition in our Cocker Spaniels. Oh yeah, miniature Schnauzer, more Cocker Spaniels, definitely lots of Cocker Spaniels. We also see it commonly found in, but we not found a genetic predisposition for poodles, Irish setters, Dobermans, Lhasa Apsus, English Springer Spaniels, and Old English sheepdogs. The signs, these guys are anemic, right? When you don't have red blood cells, you are now anemic. And so They can present weak or collapsed, lethargic, dull, depressed mentation, pale white gum color, bounding pulses, heart murmurs, or tachycardias. Rarely, but sometimes, they can get a fever due to the immune or inflammatory response. Very rarely, they can have a hypothermia due to the anemia. So human patients that are anemic describe themselves as being cold and chilly all the time, because when you don't have red blood cells, you probably are cold. So keep that in mind. The spleen and the liver may also become enlarged. More commonly, the spleen, though, and that is because the spleen actually contains extra red blood cells, but it also is the main organ that houses all the deceased red blood cells and disposes of the red blood cells parts. The liver does that as well, but the spleen will become enlarged because that's where the red blood cell destruction occurs. Now, interestingly enough, when a red blood cell dies, when it goes like that, bilirubin gets released into the bloodstream. The liver can become overwhelmed. So just think about all these red blood cells, bilirubin getting spilled into the bloodstream. All of a sudden, the liver's like, wait a minute, I don't have time to process all this bilirubin. So what do you end up with? Yellow patients, right? So when this process continues on and your patient starts to become yellow, that's why. So how do we diagnose IMHA? It really relies heavily on the blood work itself. On a CVC, when we do our beautiful blood smear, you know, it is really a gift to be able to do a blood smear perfectly the first time. I know, like you when you get that gift and you feel like you're such a winner, you take that beautiful feathered edge and you whip it out and you go, yes, I've done it. I've seen people post to Facebook about it. Look, this was the first, how pretty is this, right? That is always fun. What you'll see on the smear, though, is that 95% of dogs are going to have these spherocytes. Those are those round spherical red blood cells. You can see the little arrow pointing there. So those are spherocytes, and 95% of IMHA dogs and cats will have spherocytes. Agglutination usually occurs. So let's talk about that slide agglutination test. Now, many years ago, one of the hospitals that I was brand newbie at, I was a VTS in emergency to critical care. I had someone come up to me and said to me, you're doing it wrong, and just walked away. Now, funny enough, I just did a podcast on harassment of new hires and the hazing that it takes place. So here I was, a VTS emergency critical care. I thought I knew how to do a agglutination test. This old cranky veterinary technician came up, just announced I was doing it wrong, and walked away. So this kind of made me think, is there another way to do it? Answer, yes. So here we go. Let's talk about it. So if this ever happens to you, you'll be happy to know there are several reported methods. If you need references, just email me and I'm happy to give you the references of these. And in doing and researching this topic, I found a myriad of ways to do it, all of which were in solid textbooks that you can all read. And so from industry leaders who have written it. And so here we go. They all involve anticoagulated blood and 0.9% sodium chloride. Reference 1 said, you just take 1 drop of anticoagulated blood, either from a purple tube or a capillary tube, and you mix it with 10 drops of 0.9% sodium chloride. I have never done it this way. I'm just going to be honest. I feel like the dilution there of 1 to 10 is a lot. And what the whole point of what reference 1 says and why they want you to do it this way is because rouleau will disperse while agglutination will clump. So what's rouleau? It's these stacked coins. So look in the upper left, you'll see that's agglutination. So usually whatever method I choose to do it, I will then look at it underneath a microscope so that I can look. And so you can see very much agglutination. On the bottom right, pennies like that have been knocked over, stacked coins. Why do we even make the penny? Did you know it takes more money to make a 1-cent penny than it actually is worth? We should just get rid of the penny. They should just, we find them on the ground. Poor penny, right? I don't know why I'm talking about pennies right now. Let's go back. All right, so stacked coins, those rouleau. That is not agglutination. All right, so reference 2 says to take equal parts 0.9% sodium chloride, anticoagulated blood, put them on a slide, rock it back and forth for about a minute. However, it also says that it's not possible to differentiate between rouleau and autoagglutination at this point. And reference 3 is kind of what I do, guilty of this. You just take 1 drop of anticoagulant blood and mix it with several, whatever a number you want to make it. Just put a couple drops of 0.9% sodium chloride and rock it back and forth. And this is more or less what I do. And then it's always still recommended to look at that slide on a microscope and identify it. Now, sometimes visually you can see the agglutination happening, and that's really cool when that happens. You're like, ah, look at that. So for me, if this animal's really, really anemic, let's just say it only has a PCV of 12%. Sometimes I need more than a drop of blood. So sometimes I will cheat because it is so diluted out, you can't appreciate anything. So to me, I kind of just do what I feel is right, rock it back and forth and see whether or not I get an agglutination. Turns out I wasn't doing it the wrong way. There's many different ways. No matter the test, positive agglutination test does not mean it's 100% IMHA, but it means that the red blood cell destruction is acute and it's severe. Now, if it's a Cocker Spaniel, it's its 3rd offense, you get positive agglutination. It probably is IMHA, but it's not definitive technically for diagnosis. A negative test doesn't rule out IMHA. The next thing you can do is obviously look for reticulocytes. So you submit out a CBC to look for reticulocytes, and these are the immature red blood cell. Now, I was giving this lecture a couple months ago, and somebody said, well, if we know how to do it in our hospital, can we look for reticulocytes? Yes, you can. But see, in specialty medicine, we become so specialized, we forget how to do certain things. And so I don't have right stain in my hospital. We send stuff out to the lab all the time. I don't remember the last time I did a fecal smear, and I looked at poop under a microscope. It's not, I probably could come up with like, oh, that's coccidia. Oh, that's giardia. That's a roundworm. But to be honest, it has been years. I take poop, I send it out to a lab. Someone else looks at it for me. So that's why I wrote submit out to a CBC. But somebody was like, well, what happens if we know how to do it? Well, you're good for you. You can do it in your own in-house lab. That is totally fine. But for us specialized people, we've become so specialized, we forget how to do stuff. Like nobody wants me doing a dental prophy on their pet anymore. Used to do them all the time, not anymore. So the formation of reticulocytes equals a functioning bone marrow, therefore a better prognosis. Reticulocytes take about a day to become mature red blood cells. Most of our pets are going to have reticulocytes. That's good news, 60 to 70%. So that's the good news. When we're losing reticulocytes and we unfortunately have that non-regenerative IMHA, very bad prognosis. The Coombs test, this is also called the direct antiglobulin test or the DAT test. This is the most conclusive test out there. I should say more conclusive test, a diagnostic test out there. It detects antibodies attached to the red blood cells. So basically it dilutes out the red blood cell until it actually separates. It pulls the antibodies off of the red blood cell and goes, I got you. This is our problem. I have identified there's antibodies on top of the red blood cells. That's your diagnosis, right? It's rare, but false positives can occur. Sometimes if you have really low circulating numbers of antibodies, you can get some false negatives. This is the case of, like, again, reoccurring Cocker Spaniel, owners super on top of it, always watching fire IMHA, and they come and they go, you know what, she's just not acting right. You go ahead to a PCV total solids, it's at 28%. You're like, ooh, that is low, but it's not terrible. You might get a false negative on the Coombs test. The test is not accurate if you do a blood transfusion or there's a large amount of agglutination. And then flow cytometry. This is a newer test that involves, evaluates antibodies in dogs. It's very specific for the diagnosis of IMHA. It detects both IgG and IgM antibodies. Anemic dogs are more likely to be positive for antibodies than non-anemic dogs. So just a quick review, IgG is this class of immunoglobulins that provides the majority of your antibody-based immunity against invading pathogens, where IgM is the class of immunoglobulins that eliminates the pathogens in the early stages of immunity before there's sufficient IgG. Let's talk about cat IMHA. You want to be sure to test for Feluke and Mycoplasma on these guys because both of those are a common secondary cause in cats. In cats, good news, it is often a regenerative anemia and offers a better prognosis. The few cats that I have seen that have gotten IMHA do actually pretty well, and I'm always shocked. They do much better than our canine patients. As far as complications go, thrombocytopenia, and we're going to break every single one of these down, disseminated intravascular coagulopathy, thromboembolism, GI ulcerations, renal failures, and refractory anemia. So let's break down these complications because there are a lot. Obviously, being anemic is not a good thing, but being anemic for an extended period of time sets your body up for all of one of these things. So thrombocytopenia. Now they can just develop a true ITP, immune-mediated thrombocytopenia, right? Evans syndrome. So again, about 60% of our dogs are going to develop ITP. The reason why they might be thrombocytopenic is because there could be a platelet consumption that occurs. The exact physiology of why ITP occurs so frequently and concurrently with IMHA, we don't know. It just does. It's ultimately, we can see DIC, so disseminated intravascular coagulopathy, that can get triggered because of thromboplastic substances that are released from the red blood cell membranes. We can also see it because of tissue ischemia from hypoxia. And ultimately, we're going to try to suppress the immune system. And whenever we suppress the immune system, we can set this body up for disseminated intravascular coagulopathy. So if we are eating up and utilizing all the coagulation factors and platelets, this animal no longer can clot. So we do want to check clotting times. You monitor for excessive bleeding, petechiations, and ecchymosis. So on this cat's belly, you can appreciate the petechiations, those little bruises all over this cat's belly. So if you're starting to see that on the gum line, the pinna of the ear, the belly of the animal, we definitely want to check our coagulation times, PT and PTT. And if we see elevations, we're going to think this animal's in DIC. Thromboembolism. Some of you have seen a lot of IMHA patients. I promise you've seen one who's thrown a clot, a thromboembolism, and you might not have recognized it. Now, there's been some recent studies, particularly in the last 2 years. In fact, the JVEX magazine just sent out a consensus study and talked about thromboembolisms in pets. Now, clots occur all the time in people. Obviously, people have a lot of strokes, and in people, it usually goes up to the brain, and then they have a paralysis on one side of the face. They start to have slurred speech or vision loss or doing strange things. And so we kind of know what a clot looks like in people, almost always to the brain. But people do get clots elsewhere too. They get them to their hearts, their lungs. This is obviously a massive heart attack. What usually occurs, we get a big clot to the heart and it just stops the heart. Now, pets do get a lot of clots, but we don't have the ability or the means. Usually it's because of financial to truly diagnose that this animal has had a clot. And so we see this in cats, right? They throw clots to their hind legs, they scream, and then all of a sudden they might drop over dead. We see this in particularly Maine Coons who have usually a history of heart disease. Owners never had the heart murmur worked up. Cats walking along, screams and drops over dead. But where we see it with IMHA is it usually goes to the lungs. So most commonly, we see pulmonary thromboembolism, and we're not sure why this happens, but we should suspect that this animal threw a pulmonary thromboembolism if all of a sudden they're in respiratory distress. And some of you, this is clicking for you, where you've had an IMHA patient, and I find it's the ones that are really bad. So they're now jaundiced, they're now icterus, they're turning yellow on you. You've given multiple blood transfusions. They're now day 3, 4, 5 of hospitalization. All of a sudden you look over and they're like, and you're like, why is he breathing like that? He's probably thrown a clot to his lungs, and that is a very bad prognosis. So there's suspected reasons as to why we think this happens. Certainly, again, the release of red blood cell thromboplastic substances, the high volume of circulating bilirubin. So that's why I said, in my view, I usually see this with the animal being jaundiced or icterus. Venipunctures or catheters, I hate to say it, but anytime you place a catheter, there's going to be microclots in that catheter. And then ultimately, immunosuppressive agents. We can see GI ulceration and bleeding. This is not an IMHA patient, but obviously massive GI bleeding. So this is vomit from a heat stroke. St. Bernard, poor guy, right? Obviously did not do very well. But this is, he woke up and puked this bloody vomit. So that's massive GI ulceration and bleeding. Usually we see the GI ulceration and bleeding in our IMHA from a secondary DIC, the use of glucocorticosteroids, ischemia injury due to GI mucosa, or thrombocytopenia. So for the most part, when these guys get admitted, or even if they're just a little bit of IMHA, because you got an owner that's really savvy on this, again, Cocker Spaniel, we're going to send this guy home with a GI protectant. And then we can see renal injury in IMHA patients, usually due to hypoperfusion, vasoconstriction, again, ischemia or dehydration. And we can also get a weird refractory anemia. And so we can initially see an elevated PCV, and then they get almost a refractory anemia. And this is direct injury to the erythroid precursors, bleeding from the GI tract, or again, suppressive erythropoiesis because of immunosuppressive agents. So let's talk about how to treat IMHA. You got to deal with the anemia. Sometimes, but rarely, we need to put them on temporary oxygen supplementation. Again, red blood cells carry your hemoglobin. Hemoglobin carries your oxygen molecule. If you don't have red blood cells, you are not oxygenating appropriately. Blood transfusion there's a lot of controversies behind that. We're going to dive a little bit into that, but there is a lot of controversies about that. All right, so let's talk about the controversies. The whole point of giving blood is that you are putting a temporary Band-Aid while you try to fix the immune system. Remember, the immune system is acting out of control. It woke up, it had amnesia, it's attacking the red blood cells. It doesn't know that it's doing something terrible to itself, but it's killing itself, essentially. So you're going to need to suppress the immune system. Now, there's some studies that have shown that blood transfusions actually worsen IMHA, just a few out there. We know that if you give blood transfusions in animals that have PCVs of greater than 22%, they have an increased risk of thromboembolism. So most texts, most literature says we do not give a blood transfusion until the PCV is at least 20 to 22%. And the problem is that when you put healthy blood in the body, what do you think the body does? It recognizes it still as some foreign insult, and it attacks it and kills it. Now, most literature states that you have about 12 to 24 hours when you transfuse the blood. Within 12 to 24 hours, those blood cells that you transfuse the body with will get destroyed by the antibodies. So you have 12 to 24 hours to fix the immune system. And so it is kind of this bad game, right? You're going to give blood. You're going to try to suppress the immune system. The body's now attacking the new blood cells, and it potentially eats up all the brand new blood. You just gave 200 mils of blood, and it's gone, right? The body 24 hours later, like, ha-ha, I foiled your plan to make me better. I have ruined your blood. And then you give another blood transfusion. You go, okay, well, I see that didn't work. Here we go. Let's give another bag. And the body goes, aha, I see you are trying to thwart me again. You're trying to save myself. That is ridiculous. I will kill these red blood cells too. But in the process, you are hoping to shut down the immune system so it stops doing that. I put this in here because, and it should say are not going to be available. My lecture notes lie. It say that it's going to soon be available. And I just noticed there's a typo here. Hemoglobin-based oxygen carriers are not going to be available. And I apologize. In my lecture notes, it says that they are, but they are not going to be available. Now, anybody who is an old dinosaur, like I described in my previous lecture, like me, you might have remembered oxyglobin. So oxyglobin was a Band-Aid because it was an oxygen carrying capacity product that you could give that did not necessarily contain red blood cells. It contained only hemoglobin and oxygen. It's actually made out of Waltham, Massachusetts. The FDA no longer allows us to carry this product. About a year or so ago, they were going to launch it again, but then the FDA said no. Now in Europe and even Australia, you can get oxyglobin, but the FDA says no go here. So we can't have it. So my lecture notes lie, and apparently so does this lie. It will not be available. But we used to give it to IMHA patients because all they needed to do was have more oxygen without necessarily red blood cells. It's actually a pretty cool product. So why do we give blood if we know that the body's going to destroy it? It's really a bad game. You give blood and hope the immune system fixes itself before it kills itself. And then you give blood and you give immunosuppressive drugs and you wait and you hope that you win this very bad game. Ultimately, we also want to support them with fluid therapy. So stabilization of patients is usually done through the use of crystalloids. Usually lactated ringers, 0.9% Normar, P-Light, anything like that is totally fine. We want to maintain tissue perfusion because if we can keep the tissues perfused, it helps to perfuse the kidneys so we don't go into kidney failure, which we know is a side effect. And it also helps to diurese out the liver. So the poor liver is getting insulted by all that bilirubin, really. So if we dilute out the bilirubin, the liver can function a little bit more. The irony to this, though, is when you add fluids. So think about a jug of water, and when you add 1 drop of blood and then mix it up. So you will result in a lower hematocrit. So if you might have started off with, say, 27%, but through fluid therapy, not because of anemia, you're now down to 23%. So it can become falsely low, but that is just because you're diluting out the body. If you have a patient that gets DIC, so disseminated intravascular coagulopathy, you want to give fresh frozen plasma. Fresh frozen plasma contains all the coagulation factors, no platelets. Some other treatments, you want to deal with any underlying causes, so reticular diseases or mycoplasma, obviously treat those. And most patients receiving immunosuppressive drugs also receive GI protectants like we talked about to prevent GI bleeding. So let's dive into the meat of the treatment, which is immunosuppressive drugs. So corticosteroids are the primary drugs used to help suppress the immune system. Still to this day, 20 plus years later, we still rely on prednisone or prednisolone. So what is immunosuppressive drugs? They reduce the phagocytosis of red blood cells. They decrease the production of cytokines, which help to mediate the inflammatory response. So we're trying to decrease that. And we're decreasing the production of immunoglobulin IgG specifically. It is not beneficial for intravascular hemolysis that is mediated by IgM. And then we certainly have other immunosuppressive drugs like cyclosporin or cyclophosphamide that can be helped to use in non-responsive pets. There's very limited studies on these. Most studies do not show that they're any more effective than the other corticosteroids. So to be perfectly honest, we typically just focus on starting with pred and seeing whether or not that works. Prednisone versus prednisolone, it's basically the difference is how it's metabolized. So prednisone is metabolized in the liver. Prednisolone is not metabolized in the liver. And so it's considered to be easier to metabolize in patients that have liver involvement, AKA those that are turning yellow on you, or cats. Now, prednisolone is usually in smaller doses. So prednisone, unfortunately, when we're dealing with big dogs, that's usually what we're going to give, regardless if it's involved in the liver or not. And then we look to see how they're responding. Is the hematocrit rising? Do they have adequate reticulocytes? Do we start to see reduced spherocytes, reduced agglutination? And then if they're not responding to pred or prednisolone, we start to think about adding in something like azathioprine. So this is used to help complement prednisone. It is very rarely do we just use it alone. I don't know of anybody who reaches this as a first line of defense. First line of defense is still pred. And ultimately, it's a purine. It mimics your DNA and your RNA, analog of immunosuppressive drugs. The study's variable when it's used in conjunction with pred. It's low cost. So to be perfectly honest, it's well tolerated in dogs. A lot of my internal medicine specialists will kind of do pred. And if it's a severe IMHA, they really have a low hematocrit, they'll automatically put them on azathioprine. IVIG, so intravenous immunoglobulin. In human medicines, this is a first line of defense, but this is a human-based product. So this is a human immunoglobulin. It's used for in veterinary medicine where pred doses are dangerously high, or we're not beating this bad game. We don't fully understand why it works. We think it helps to work on the cytokine network or help to neutralize autoantibodies, and it's thought to inhibit the binding of canine IgG. Now, there's really not a lot of studies being used by itself. So veterinary IVIG is expensive. It's periodically not available. And because it is using this IVIG in veterinary medicine, it's a human-based product, pets can actually develop a hypersensitive reaction and have an anaphylactic reaction. The only times I've ever seen it used is where we've given like 4 or 5 blood transfusions. This animal's on azathioprine, pred. We are trying everything. This animal's yellow. They're usually in respiratory distress. We call the human medical hospital down the street and we say, we need some IVIG, and we give it a try. So currently, it's usually only recommended in conjunction with pred or pred has failed miserably. And then cyclosporine, it's a second line medication. Again, this is not going to be the only thing. Pred's still the first thing. It's usually Novartis is the one that makes it. It's widely used in people for IMHA and transplantation surgery. So if I had kidney transplant, they would put me on cyclosporine. It helps to decrease factors that stimulate an inappropriate autoimmune response. It's well tolerated in dogs, not as common in cats to use it. Sometimes you can get some rare GI signs. Usually once you discontinue this product, it tends to resolve. So what I find most of my doctors do, start them on pred, and then if it's really a bad IMHA, also start them immediately on azathioprine. And they usually almost always add in cyclosporine, to be perfectly honest. And then Danazil or Danocrin, this is a secondary line medication in people. We don't typically see a ton of use in veterinary medicine. It is considered liver toxic in dogs. Rarely do we use it though, but again, if all else is failing, this is something to consider. And the very last resort in IMHA only patients is a splenectomy. So this is, the reason is because the spleen again helps to decrease. If you remove the spleen, a decrease in red blood cell destruction will occur, because that's where all the red blood cells are destroyed, are going through the spleen. It is an option in reoccurring IMHA patients. I have never seen it done, but I know of it and it's in literature still. There's numerous risks. Obviously, if the animal can't clot, if they're in DIC or they're an ITP patient, like an Evans syndrome, this is a no-no. And in people, when they've removed the spleen of an Evans syndrome patient, they've actually had higher mortalities. So this would be maybe something to consider in a Cocker Spaniel where it's like 4th or 5th offense, and you think maybe we remove the spleen of this Cocker Spaniel and see whether or not this stops it, right? Prognosis, better in the cat than in the dog, and I totally agree with that. It is really the number of blood transfusions is a negative prognostic factor in IMHA. Once they get over 3 blood transfusions, it's probably a really bad prognosis. It's because that's showing you the severity of the disease, and you can get transfusion complications as well. We certainly know if they develop Evans syndrome, it's a worse prognosis than just IMHA or just ITP. And if they develop DIC or thromboembolism, something like that, it's obviously a worse prognosis. So now let's break down ITP. And you're going to find there's a lot of similarities with immune-mediated thrombocytopenia. So 2 causes, right? Looks familiar: primary, idiopathic, or secondary drug-induced or cancer. So the antibodies are now produced against the platelet antigens, which destroy the platelets. The spleen is the major source of antiplatelet antibodies. And platelet lifespan is correlated to platelet-associated antibody levels. So normally your platelets live in your body for about 4 to 8 days after you make them, then they become functional. It takes about 4 to 8 days is their life expectancy before they die. In ITP patients, it's less than a day. And here's the worst. In ITP patients that have high level of antibodies, it's less than an hour. So remember how we talked about it with IMHA patients, when we give a blood transfusion, those red blood cells stay alive in the bloodstream for anywhere from 12 to 24 hours, depending on which study you want to believe. But you got at least 12 hours to try to make a difference in that body, and that's a good amount of time. If you give an animal platelets that has ITP, they are literally destroyed within under an hour. So therefore, we do not do platelet transfusions. So platelets, though, that do survive go on to function normally, but we don't give platelet transfusions because it's a waste of the money. And because, again, it's unfortunately, they don't live very long. Immune-mediated thrombocytopenia is not as common as IMHA. It is more common, though, in dogs than in cats. Predisposed, does this look familiar? More common in middle-aged females, and breeds includes Cocker Spaniels, Airedales, Dobermans, Cocker Spaniels, Old English Sheepdogs, Cocker Spaniels, Poodles, Cocker Spaniels. You see the theme here, but definitely the same sort of similar breeds, right? Clinical signs, they can't clot. So because they don't have platelets, we're looking at petechiations and ecchymoses, melena, hematuria, retinal hemorrhage, epistaxis, and we start to see really severe worsening signs when they have severe thrombocytopenia, which is defined in less than 10,000 platelets. Diagnosis, we're going to perform a platelet count. Now, if you look at the slide down on the bottom right there, you see those little specks of blue between the red blood cells? Those are platelets. It's always best to send out a CBC and ask for a manual count. Honestly, the people who work in the lab, they do this every single day. They're going to be able to count platelets way better than anybody else because that's their goal. They are so specialized. That's all they do. And they're probably saying, I don't remember how to do vaccines, but I'm really good at doing platelet counts, right? So once we get a count of less than 30,000, in addition to a low mean platelet volume, it's highly suggestive of ITP. So what is a mean platelet volume? This is the average size of the platelets. And so when we send it out to a lab, they can actually calculate out what a mean platelet volume is. So the marrow releases these high number of immature platelets. If you've ever seen a megakaryocyte, it is like a gigantic blob of blue, right? It looks huge. You're like, what is that? What? I don't understand. And you'll see a bunch of them. Those are megakaryocytes. And megakaryocytes are gigantic. And the number of mega drop in the bone marrow. And so a 2008 study said that MPV is almost 100% reliable when differentiating out ITP from all the other thrombocytopenias. So we can do these in-house platelet counts. So basically to do an in-house platelet count, you count 10 high-powered fields, always on the feathered edge, particularly in cats. So that's where they like to hide all of their platelets. And you multiply that by 15,000, and then you divide by 10 to get the average per field. A normal patient should have anywhere from 200 to 800,000 cells. You can also do an ELISA test, this test for the presence of platelet antibodies. It's not specific to ITP. If you get a negative result, it doesn't mean it's not ITP. If you get a positive result, it just means it's thrombocytopenia, but it might not necessarily be immune-mediated. Complications of ITP, big one, DIC, right? So disseminated intravascular coagulopathy. So when we have ITP patients, check the PT, check the PTT, look for that patient having signs of excessive bleeding, petechiations, and ecchymoses. So how do we treat these? Again, as I already stated, we do not transfuse with platelet-rich plasma or whole blood. Those are the only two products that contain platelets. Platelets are only contained in whole blood or platelet-rich plasma. Platelets are extremely fragile. ITP immune system destroys platelets within hours. So again, you can't do any change within that immune system in that amount of time. So there's literally no point to giving platelets to an animal that has ITP. Where references in textbooks will tell you to consider giving a platelet-rich plasma transfusion is if you're going for splenectomy, obviously. I've never seen it done. I would say that's probably a really bad prognosis. So how do we suppress the immune system? It's going to look very familiar. Corticosteroids like Pred or prednisolone, right? So we're going to do the same thing that we do to the IMHA patients. We're going to do the ITP patients. And certainly consider other adjunctive therapies like azathioprine, cyclophosphamide, cyclosporine, danzanil, everything we've already talked about. But then here's the added one. So vincristine, if you've not seen this used for ITP patients, it is amazing. Started using it probably like 10 or 15 years ago. It's a conjunction therapy, so we don't just use this. We use it in conjunction with Pred. It interferes with some immune system response on platelets, and it helps to mature those megakaryocytes into functional platelets really faster. A lot of studies have shown that vincristine plus Pred helps dog reach 40,000 cells a lot faster than Pred alone. I tell you, it is pretty awesome. And think about what chemotherapy is. Chemotherapy, because a lot of you going, Amy, we're not trying to cure cancer here. I get it. But chemotherapy is suppressing the immune system and is essentially trying to kill the bad cells without killing the good cells. And a lot of times the body made those bad cells, right? So you're killing off some good cells regardless of what chemotherapy you decide to use. And that is the case of vincristine. But what we found is that vincristine actually takes those megakaryocytes and turns them into functional platelets. It is so cool. I tell you, you get an animal in that has maybe 2,000 platelets and they've got like retinal hemorrhage, nosebleeds. You're like, this animal is going to die. You start them on Pred, you give them vincristine. 24 hours later, you look and you're like, where did all these platelets come from? My goodness, look at them all. It's really, we use it a lot in conjunction with Pred for that reason. Let's talk about the nursing care of both of these guys. So obviously, we already talked a little bit about how these animals, Evans syndrome patients, they're IMHA and ITP. So initial presentation, you might have to just get them over the hump with supporting them with oxygen. You want to give oxygen the least stressful way possible. So think about oxygen cages or oxygen hoods, that sort of thing. And we're going to monitor their level of oxygenation through maybe arterial blood gas, pulse oximetry, respiratory rates and effort, auscultation of the lungs, and gum color. And then certainly we talked about blood products. I love this picture so much. I don't know who created it, but it's awesome. So we want to think about giving blood products, and really monitoring is key when giving any sort of blood product for blood transfusion. There's a greater chance of reaction when we give blood products as opposed to, regular types of fluids. There you get the greatest chance of reaction whenever you give whole blood. Blood typing, cross-matching, transfusion monitoring really is key. And there's really mixed views on whether diphenhydramine helps or not. As far as the fever, which is the most common blood transfusion reaction, I think it's something like 90% of dogs and cats will experience some temperature increase when giving any sort of blood-related product. That is considered a normal transfusion reaction. Diphenhydramine has pretty much been proven not to help. Where diphenhydramine, there was one study that showed that it decreased the chance of an animal getting urticaria, aka hives, breaking out in hives, by about 20% if you give diphenhydramine. That's the only study that says giving diphenhydramine will help with blood transfusion reaction. Physical exam, we really want to monitor these guys every 6 to 8 hours, heart rate and pulse, respiratory rate and effort, gum color, capillary refill time, temperature, how are they doing neurologically? And then other parameters, we really want to think about really monitoring their blood pressure at least twice a day. If we placed a central line, and the only time we would do that is if they were only IMHA, we can monitor central venous pressure, consider monitoring their lactate levels, and certainly watch for DIC. So we're doing a lot of PCV and total solids checks. We're doing maybe blood gas monitoring. We're checking their kidney values. When you do a venipuncture to stick and you're a good technician, you put the little boob bandage on and you remember to take it off in a timely fashion so they don't get fat foot. When you take the boob bandage off, if they're still bleeding and they weren't doing that the last time you did this blood draw, you gotta alert your veterinarian that you're concerned about DIC. Blood pressure is really key in maintaining good pressure in these guys because, again, we talked about how they're predisposed to going into renal function. So we really want to maintain that mean arterial pressure between 80 to 100 to 110 millimeters of mercury. If you're doing Doppler, it's probably only going to monitor systolic blood pressure, so you want that reading to be anywhere from 80 to 100. But what we really want to know is that mean arterial pressure is above 60, because it's going to be important to keep it above 60 to perfuse the brain, the kidneys, and the heart. Anything below that, we're going to get organ dysfunction. Lactate's a measurement of perfusion. And really, I think every general practice, every veterinary hospital should be measuring lactate. It accumulates due to the inadequate oxygen availability. Yeah, I would say we don't have a lot of oxygen in our body right now. And this is caused by tissue hypoperfusion. So we might think this animal doesn't need to be supported by fluids, when in actuality, we need to actually give them a few boluses because their lactate's too high. So anything under 2 or 2.5 is considered normal. This 11.4 is really not compatible with life. Nutrition, this is often overlooked. And anytime an animal doesn't eat for more than 2 days, we really want to get nutrition into them. It helps to minimize their weight loss, but it also provides adequate energy for metabolic support. There's not a disease on the planet that doesn't benefit from nutrition. And we find with our IMHA and ITP patients that they have a better outcome when we receive early nutritional support. So tempt these guys to eat, record what they ate and how much they ate. And they might not be able to get up. Remember, they don't have red blood cells. They can't oxygenate very well. So turn them every 4 to 6 hours. Don't leave them on their right side. You got to turn them on their left side, sternal, get them up, keep them free and dry of bed sores, bathe them to avoid scalding if they're actually urinating on themselves, offer a lot of soft bedding and change it once a day. And if they're really struggling to get up, like in a large dog, consider placing urinary catheters so they're not weeing all over themselves and getting that urine scald. Also consider passive range of motion, so mobiling their legs and making sure that they're not going to become stagnant. So in conclusion, the patient's condition may change very quickly depending on the progression of the disease. It is imperative that appropriate nursing care is provided to them to allow for best prognosis. This is my very handsome border collie, Havoc. He is appropriately named because should you not throw the tennis ball fast enough, he will wreak havoc by barking at you. My email address is there. My website is there. And again, I know I'm a fast talker. I'm happy to take any questions, but again, I have very thorough lecture notes, or just reach out to me if you ever have any questions. Thank you so much for listening. Hello, we're back. So now we're going to be talking about thoracic radiology review, seeing the hidden stuff. Again, my name is Amy Newfield. I'm a veterinary technician specialist in emergency critical care in Massachusetts, where it's freezing cold and I'm waiting for the spring to happen. Right now, I wonder why I live in this state. But it is pretty getting all 4 seasons. So my email address is at the bottom there. And be sure to reach out to me if you have any questions. As some of you have already know, I'm a super fast talker. And for that, I do apologize. But my lecture notes are very thorough, because if you want to try to write down everything I'm about to say, you're probably going to get a hand cramp. So instead, just listen and then refer back to the lecture notes. All right, so this is not really about positioning, but I do think it's key for us to make sure we get good positioning so that we can then really do a deep dive into what are we seeing on radiographs. So we want, usually when we're taking lateral radiographs, we want the legs out of the chest. The ribs should be parallel to each other and never dorsal to the spine. They shouldn't be separated. I'll show you images of plenty of bad films. In fact, to be perfectly honest, getting a great lateral radiograph on a chest film is really hard. And I know what a lot of you are saying, Amy, I take amazing lateral radiographs all the time. How dare you? But I promise you, when you see the images, you're going to be like, oh, yeah, okay. You want to collimate from the thoracic inlet all the way down to the last rib, and right lateral is generally preferable, and that is what is being taught in our schools. So here is a terrible film. And so when we take a look, we've got the legs pulled into the chest. If you look at the heart, there's kind of a weird, like almost a silhouette that looks like this over top of the heart. That's actually the muscle mass on the dog's leg that's protruding over the heart. You can also appreciate how the ribs are not lined up like this. They should be stacked over. Instead, they're like this. And so we have, you can see almost every single rib. The other thing is the dog is rotated. And so when I said it's hard to get a good film, you're going to see a lot of rotated films. So rotation occurs, as we know, we pull the legs out of the view, and then all of a sudden the dog goes, no, no, or the cat goes, no, I don't want my film taken. And so that twist causes, if you look, you'll see that the ribs are on top of the spine. That's not a good thing. That means the animal has twisted itself. And we are going to see a lot of ribs on tops of spines because of that reason. All right, this dog is still not flat. So this dog is an amputee. You can see those little white things kind of to the left of the words where it says ribs not parallel. If you look, those little white things in there, those are staples from a leg amp from years ago. So it's really hard because you only got one leg to get that dog straight. So again, ribs are not parallel. They need to be on top of each other. And look at the ribs above the spine. What a freaking mess. Beautiful. Mwah! Love this film. Take a look at it. Thoracic inlet. That's the first yellow arrow you see on the left side there, all the way down to the last rib. And take a look how big the lung chest is. It almost goes down to the very last rib, which is why we have to get the whole chest in. If you have a Great Dane, you might have to take a cranial and a caudal chest film. That's normal. But you know what else you see? You see the ribs below the spine. That is because the animal has not twisted itself. And you see how wonderful that they are parallel. Now, you will get some separation of the ribs as it moves down the chest, but the very first set of ribs should always be on top of each other. This is a beautiful film. So we always want to focus on a VD, a ventral dorsal, so this way, right? Rather than a DV. You can't, now I said in the abdominal one, there's no point to taking a DV. You're not going to see anything. But there is a point to taking a DV on a thoracic film. VD is preferred. It generally gives better detail when pleural effusion is present. On VD, the spine has to be superimposed over the sternum, so they have to be lined up. And again, you still collimate from the thoracic inlet to the last rib. Now, on a DV, it's going to cause the heart to be more cranial and in the left hemithorax. So that's what you see here, where the heart is shifted a little bit to the left. Again, remember, your right is the animal's left, because when we're doing a film, right, and we line up against the back of the animal, if we're shooting DV or VD, so keep that in mind, and you want to label properly. Well, did you shoot a VD? Did you shoot a DV? What does that look like? Is this heart big? No freaking clue. No idea. Why? Because the spine and the sternum are not lined up. Sternum's over here, spine's over here, animal's crooked. No idea. We don't know what's going on with this animal. Beautiful. Mwah, love it. So we take a look at this film. The legs are pulled out of the view. The spine and the sternum are superimposed over each other. We've got equal lung fields. We've collimated from the thoracic inlet all the way down to the last rib. That's what that should look like. I know there's a lot of things, respiration and radiology. Yeah, absolutely. Inspiration is preferable because it provides better contrast. Subtle lung lesions are more visible. However, it is exceptionally difficult to deal with a patient to get them to only have an inspiration. Excessive panting can cause motion, and so we don't also want to stop dystonic animals from panting. So do your best. A lot of people will kind of do a quick like breathe into the animal's nose and they go, why are they breathing on my nose, right? But sometimes breathing onto their nose can cause them to wiggle and move. So do your best. Normal thoracic radiograph, it really depends on species, age, breed, sex, and body condition. These are all normal, but very different chests. And so you can take a look. There's all right laterals, except for the bottom middle one is a left lateral. And so we take a look at the shapes of the heart. We've got in the bottom left, very round, rotund heart. Nothing's wrong with it. That's normal. We've got obviously all of these skinny little hearts that we've got going on. You know, you've got deep chest. I mean, you take a look at the upper middle one, right in the middle on the upper line here. Look how deep that is. I mean, it keeps, the lung field just keeps on going, right? So we see very normal but different chests. There are 5 main areas, sort of like the 5 main areas of the abdominal cavity. We also have 5 main areas of thoracic cavity, but I don't have a cool acronym for you guys. So we have our extrathoracic, very, very similar, like the extra-abdominal, pulmonary parenchyma, the pleural space, the mediastinum, and the diaphragm. So let's talk about normals versus abnormals. So the pleural space, it's very similar if you attended the abdominal one, is that lining of the thoracic wall, the diaphragm, and the lungs. And it's divided into the parietal. So the parietal is the inside lining of the chest cavity, basically. The visceral covers the lungs themselves. We don't normally see the pleural space. It's divided into fissures. And so for some of you, you might have heard your veterinarian say, oh, I see a fissure line. What the heck does that mean? Here's fissure lines. So the pleural space isn't continuous like it is in the abdomen. It actually juts in. It does these weird things. So it'll come up and then it'll jut in, come back down, go a little bit further, jut in, come back down. I don't know why it's like that. It just is. And so these fissure lines, we don't normally see them, but when they become filled with air or fluid, they can become prominent. So pleural space abnormals is when now we start to see this abnormal accumulation of air or fluid. And we can get visible fissures. So fluids can just be in those little fissures itself. So pleural fissures are kind of these wedge or thin lines. And so if you ever see, oh, I hear, you know, somebody say, oh, I see a fissure, that's what they're talking about. Look at this. This is classic textbook. I love when we get radiographs that are this easy to appreciate. Over on the right, that's the pleural space. And then we take a look on the left. And look, those little wedges coming up, you can just see that fine line on the very upper one. That's actually fluid in those same spaces that you see on the right. Pretty cool, right? And so sometimes the fluid can be very subtle, but it's not normal and it shouldn't be there. We all have heard of pleural effusion, right? This is that abnormal collection of fluid between the thin layers of pleural tissue. You can get a variety of colors like you see here. Fluid is typically symmetrical. So when taking a VD, you're going to see fluid usually being equal. If it's only on one side, we think about tumor, inflammation, or pyothorax. So when we take a look at this film down here, you know, I kind of go through the same mantra every time I look at a chest film. This is what I say. Does it have an intact diaphragm? Yup. Does it have clear black lungs with good vessel structure? Not really. Do you see the heart? No. How are the bones, the extra thoracic area? They look okay. So then you have to ask yourself, what's causing the missing heart or the black lungs that are missing? And that's obviously fluid. So fluid, if we get bloody fluid known as a hemothorax, we think about things like trauma, cancer, and usually it's because of hemangiosarcoma or mesothelioma, coagulopathies. If we get serosanguinous, this is a very common in our cats. You see this probably a couple times a year where the cat comes rushing to your hospital, fluid, clear fluid is pouring out of its nose. That's because of heart failure, vasculitis, diaphragmatic hernias, or cancer. Pus, pyothorax, abscesses or infections. We see this a lot in big dog, little dog, or cats. I see it very frequently. Cats get in a fight and one clamps onto the thoracic cavity and causes a pyothorax. chylothorax. So this is lymphatic fluid, a mediastinal mass, idiopathic cause or heart disease. So pneumothorax, this is where we now get air trapped into that pleural space. And lateral view is going to be best able to view it and diagnose that's got a pneumothorax. And there's actually 3 types of pneumothorax. We have our open. It is very obvious. There's a direct opening from the chest to the inside. Gunshot wounds, stick impalement, big dog, little dog, that sort of thing. Closed, we see this during hit by car, blunt traumas. Dog gets hit by a car, and then their lung pops, right? And now they're breathing, but every time there's a hole in their lung, every time they're breathing, the air is now getting leaked into the chest cavity. And then tension pneumo, we see this when, like, usually it could be big dog, little dog, or a cat fight. A tooth goes in, it's pointed, and for a very brief moment, there's an opening from the outside. But as the tooth pulls out, it seals it up. And now air is trapped on the inside, and that's called a tension pneumo. So we take a look. Here's a right lateral. Now, look, I said it's hard to get a good film. I want you to appreciate the fact that this dog is rotated. You see the ribs above the spine and see how they're not lined up perfectly? Dog rotated. Probably the least of its concerns, and we're not going to push this dog to getting a perfect film because it definitely has a pneumothorax. The heart should be sitting right against the sternum, and it's not because it's being picked up by air. Here's the same dog, and you can appreciate we did a DV view. The reason why we did a DV view is because this dog could not breathe. We didn't want to put it on its back because we were afraid we were going to kill it. So you can appreciate the fact that it's hard to really diagnose a pneumothorax. But what you can see, again, do you see an intact diaphragm? Yes. Do you see a heart? Yes. Do you see good vessel structure? Not great. And that's because there's pulmonary contusion. So there's bleeding into the actual vessel structure, like at the alveoli. You can see that. You can see more vessel structure on your left. The dog's right there. A little bit better than on the right. And then the air is obscuring pretty much all the other details. So it's really hard. Pneumothoraxes are best diagnosed on a lateral for that reason. The pulmonary parenchyma, this is comprised of 2 equal lungs, pulmonary veins and arteries, and bronchi. So let's talk about pulmonary vessels, because you might have heard like your veterinarian saying, oh, that vein's so big, or wow, that artery is so big. So they supply the blood from the lungs to the hearts, and arteries and veins really should be the same size. On a lateral view, arteries lie dorsal, so on top of the veins. And the caudal lobe, they're all superimposed. Don't worry, I've got pictures for you. In the VD, arteries are lateral to the veins. Okay, so A becomes for B. So A will always be on top before V. So there's your artery, there's your vein. Here it is, coming up. And this, you can only really appreciate this in the cranial, meaning closer to the head view. If you look down at the caudal, meaning towards the butt end, see how they're all mismatched together? You can't really appreciate what is an artery versus a vein. So the size of the vessels does matter. On a VD, we're going to look over the dog's 9th rib, and on the cat, the 10th rib. The artery and the vein should be about the same size as the rib. On a lateral radiograph, this is a little confusing, but don't worry, we'll walk through this. About 1/3 of the diameter of the proximal portion of the 4th rib where they cross. All right, 4th rib, again, slightly rotated. You can appreciate the slight rotation because the ribs aren't perfectly lined up, right? So count 4 ribs over, 1, 2, 3, 4. It should be 1/3 the size of the proximal portion of the 4th rib. So there's the white line, that's the width of the rib, right? It's about 1/3, those little yellow lines. So again, artery on top, vein on the bottom, right? So that's about 1/3. So these are healthy looking veins and arteries. Now, on the dog, on a VD, you're going to look at the 9th rib. On the cat, you're going to look at the 10th rib. This is why it's so important things are even, right? So we're going to count down from the top. We're going to get to the 9th rib, and they should be equal. So here they should be equal. I've labeled artery and vein for you. So A becomes for V. So artery before vein. So you can see those lines coming down. If we were to measure out how wide they are, they're about the same size as the 9th rib. It doesn't have to be perfect. It's close enough. So yeah, I would agree with that. Pulmonary vessel abnormalities, when we get both the veins and the arteries enlarged, we think about PDAs like patent ductus arteriosus, left-sided heart failures, or fluid overload. If you have both arteries and veins small, we think about hypovolemia, shock, or dehydration. Like I see this all commonly in parvo puppies. If we have the arteries that are enlarged, but the veins are normal, we think about pulmonary thromboembolic disease or heartworm disease. If we have arteries that are normal, but the veins are enlarged, we think about pulmonary congestion or left-sided heart failure. So when we're looking at pulmonary parenchyma abnormals, I always ask myself, are the lungs abnormals? Are they too lucent or too opaque? Are they too black or are they too white, essentially? If they're too lucent, meaning too black, we look for overinflation or overexposure or overdeveloping. Hyperinflation, usually I find this to be the case like if the patient's anesthetized, or severe emaciation. If they're too white, and you don't see good vessel structure, I think about tumors, pleural effusion, so fluid obscuring, or pulmonary pattern. So let's take a look at Oreo, a Siamese 12-year-old female spayed. History of fibrosarcoma, left front leg amputation, anorexia, and the owner said, she just doesn't seem right. That's legit what they came in for. She's not eating well. She just doesn't seem right. This is why I wish I was in person with you, because honestly, it's so hard. I'm sitting in my basement office all by myself, just yammering by myself. Like there's nobody here. Sometimes my dogs come down to see me and my cat might peek around the corner. But this is the slide where if I was with you, I would look upon the audience and you all would be like, I don't get that. Nobody does that for me. So I'll just make the face. Okay, it's definitely too opaque. This film is way too white, right? It's crazy. So again, you know nothing about radiology. Here's my mantra. Do you see an intact diaphragm? I do. It's beautiful. You can appreciate that on the lateral field. Do you see clear black lungs with good vessel structure? No, I don't, Amy. Do you see a heart? Nope, it seems to be missing. How's the extra pulmonary or the extra thoracic area? Okay, well, great. Yeah, the cat's missing a leg. You can look on the far left film. If you look up, you see one leg and the other one's obviously missing. But yes, it looks okay. It has some degeneration of being an older cat. And again, you can appreciate rotation on that lateral, right? See how the ribs aren't lined up. So it's very hard to get a good film. But yeah, this is a massive amount of infiltrative masses. And this occurred over time, which is why this cat compensated so well. Then we have Simon, an 18-year-old male neutered domestic long hair, anorexic for 5 days, severely dehydrated at 12% and muscle wasting. All right, it didn't matter what we did for the exposure. We brought in our boarded radiologist and they just were really struggling. First of all, you can see how emaciated he is because of his concave on his back. The thing is that fat helps to contrast radiographs. And when we have no fat, 0% and more, and they're dehydrated and they don't even have fluid in their tissues, you can get films like this. And so on the bottom right is a normal looking cat. On the upper left is him. And it's just really hard to see anything that's going on because of how sick this cat was. Pulmonary patterns. Some radiologists actually advocate against classification because it pigeonholes you into something and you might be misled into diagnosing something that is not necessarily it, but they really can serve a purpose. And so there's 4 types of pulmonary patterns: alveolar, bronchial, vascular, and interstitial. Oh, alveolar. So alveolar occurs when there is fluid in the alveoli. Alveoli are those little air sacs. And so essentially fluid gets in them and then we don't see pulmonary vessels. So these little air sacs sit throughout the lungs and you can see veins underneath them because veins have fluid, right? Well, if there's fluid inside the air sac, there's no air that is passing through that, and it's all fluid filled, you lose the pulmonary vessels. The causes, things like blood, contusions, thromboembolisms, and trauma, cancers, lung collapse, or left-sided heart failure. So we're gonna look at Killer. He's a Shih Tzu, 3-year-old male, intact. He escaped from the yard, likely looking for some lady love since he's intact. He came home bleeding. The owner's like, I don't know what happened to him. He's got bruises all over his abdomen. He's breathing heavy. He has road rash. We say, Killer, you clearly got hit by a car. His heart rate is 200. He's panting. He has pale gum color. He's in shock. He's got a blood pressure of 80. Take a film. Now, for those of you who attended the first lecture, where I outed myself when I said, you hold the film up to view it. And in that moment, I realized I sounded like an ancient dinosaur because no one holds films up anymore because we're not hand dipping anymore. Amy, that was years ago. Even my own hospitals moved into the digital age. When we moved away from hand dipping and we started going digital, I thought, there's no conceivable way that these digital films are going to be as good as my most amazing technique of breathing in these chemicals and holding it up on a light box. Plus, there's something magical about holding it up on a light box. I don't know what it is, but there was the smell. I could still know. Some of you are like, I know that smell, Amy. I know. You are also survivor of this industry. So here's the thing. Obviously, we went digital, and I have to fully admit digital is way better, probably for our health and all those reasons. See how the ribs aren't parallel? Another bad quality film, people. All right, so take a look. We have an intact diaphragm. We can see a heart. Do we have good vessel structure? No. Okay. What's going on with the extrathoracic area? I see crisp white bones. That's cool. All right, so take a look at this viewed in. We don't see vessels because there's fluid all in here. This is pulmonary contusion. So we bled into our lungs. And so that's what that pulmonary pattern is. Bronchial, this is my favorite. This is my favorite respiratory pattern that you see on radiograph. It's an abnormal opacity within the lungs from either fluid or abnormal cell accumulation along or within the bronchi. What you get are these excessive number of parallel lines or rings. It's normal for older animals to have bronchial mineralization. So as animals get older, things are just going to look a little whiter in there, and that's okay. The causes of bronchial patterns are edema and allergic bronchitis. So minnow, domestic short hair, see how the ribs aren't parallel, literally. Now you're going to go back and look at your films and thought, I thought I did an amazing job taking chest films, but Amy is right. They're rotated. The animals are like, no, I'm not getting them straight on. So minnow, domestic short hair, 5-year-old female spayed. She presented for dyspnea, acute onset, no heart murmur. We're like, what's going on? This cat is basically like, okay, minnow, what's going on? We take a look. Intact diaphragm, yes. Heart, correct. Can I see vessels? I can actually. In fact, in the cranial aspect, you can see an artery and you can see a vein. I can see that, but the lungs are too white. I don't see black lungs. I see whitish lungs, right? And in a 5-year-old cat, that's concerning. And then the extrathoracic area looks good. So we're going to zoom in. Oh, do you see those little circles? That's amazing. This is why digital has won me over, people. See all the little circles underneath those arrows here. Wait, what? I did magic PowerPoint for you. Amazing. So those little circles are diagnostic for feline asthma. So little minnow, we can look and we can zoom in with our zooming in techniques that we have with digital, and we can go, feline asthma. That's very classic right there. Vascular pattern. So vessels have become enlarged, causing that increasing opacity. And usually we see that through severe heartworm disease, patent ductus arteriosus, or fluid overload. So this is Cookie, a female spayed 8-year-old lab, presented day 1 for pancreatitis. So I want you to notice the dog is rotated and the heart is off of the sternum, which might lead you to believe it has a pneumothorax. No, nay, she does not. It's just that this dog is so rotated that the heart has lifted up off the sternum. Now look at the ribs above the spine and the non-parallel ribs, right? So very rotated dog. We take a look at this film and you might think, okay, intact diaphragm. Yeah, cut off a little bit. But intact diaphragm, heart, okay. Extrathoracic area looks all right. Black lungs, oh, they look a little white, right? I know what you're thinking. She's 8, bronchial mineralization, totally normal. Can you see good vessel structure? I can. And so there's actually nothing wrong with these lungs. This is what an older dog will look like. So just keep that in mind. This is the same dog. I'm not making this up. Day 3. What happened? What happened here? So just take a look. We've got in it, you can't even see the diaphragm. You can kind of see the heart. But I'm going to do side-by-side comparison of vessels. Day 1 is on the left. Day 3 is on the right. So she was on an appropriate fluid rate. But how one dog reacts to fluids and how another dog reacts to fluids can be two totally different things. And she was on a high fluid rate, but it was still within normal limits because she was a really sick pancreatitis. But unfortunately, she went into fluid overload. Look at the size of those vessels. Oh my gosh. And so we fluid overloaded this dog, which means now she no longer needs fluids. She now needs diuretics. She needed oxygen support. She needed to be hospitalized for longer until we got rid of all this fluid out of her system. And the interstitial pattern. So you can have structured or unstructured. So structured is localized metastatic neoplasia. It's possible, especially in Shelties and Collies, to develop pulmonary osteomas. These are small mineralized nodules, and they'll look like tumors, but they're not. An unstructured pattern means diffuse and spread throughout. It's like lymphoma or vasculitis. It could also be a film was underexposed or taken during expiration. Diffuse and spread throughout. This is an unstructured pattern, right? So this is lymphoma that has spread everywhere. And can we see vessels? No. Yes, the dog has an intact diaphragm. Ribs are not lined up. See how also ribs are on top of the spine. And then the heart, we can see that. But this is an interstitial pattern. The mediastinum, structures in the middle, right? Media meaning middle, right? So we're going to talk about the heart, the trachea, the caudal vena cava, the aorta, and the esophagus. However, we are not going to talk about we will talk about the esophagus, but usually you can't see it. So the things that are visible normally, heart, trachea, caudal vena cava, and aorta. We don't really want to see the esophagus. And obviously we're going to talk about why we would see it on radiograph. Best viewed on lateral, because why? If everything's in the structure in the middle, this big bone, your sternum, now is obscuring all the structure in the middle. So it's hard, in fact, impossible to evaluate any of the mediastinum on a VD or a DV. So let's talk about the aorta. This is the largest artery in the body. This supplies your oxygenated blood to the body from the left ventricle. In older cats, it loses its elasticity. So I always like to say the aorta is the thing holding the heart up. But it can be easily misinterpreted as a pulmonary mass because unfortunately it kind of starts to fall forward and curves. You'll see it. It appears larger and kind of sometimes looks a little wonky. In VD or DV, an aortic bulge may indicate PDA. Caudal vena cava is the largest vein in the body. This supplies your deoxygenated blood back from the body to the heart and empties in the right atrium. It varies greatly in size, increases with CVP. You want to see 1-to-1. So just remember, arteries and veins should be the same size to each other. Arteries and veins, aorta and caudal vena cava is an artery and a vein. They're just bigger, right? They want to be the same size. So arteries are on top, veins are on the bottom. So again, if you look in the cranial aspect in front of on the left-hand side, basically, you'll see that artery and vein, that big line on the top, that's the aorta, and on the big line on the bottom, that's the caudal vena cava right here. So they should be about the same size to each other, aorta and caudal vena cava. So cardiac normals, we're talking about egg-shaped hearts, right? They're tilted at about 45-degree angle. So we want a nice 45-degree angle and pointed sort of upward. They should be sitting against the sternum, pending we took a good film, right? In older cardiac normals, the heart will start to fall forward and the exaggeration of the aortic arch will happen, particularly in cats, like we already talked about. We can also get fat heart syndrome. Yeah, I think that should be actually what it's medically termed, fat heart syndrome. So this causes an increase in pericardial and thoracic fat to make the heart appear large. This is an older cat. Its heart got tired. It fell over. The end. So you can appreciate this very exaggerated aorta, then how it curves and how people might mistake this as actually a problem. This is very common in cats where their little old heart just goes bloop and falls over. We lose a 45-degree angle and just falls over flat. This is a fat dog heart, so normal weight size dog. And remember that when you have fat and muscle, it contrasts differently. So it is hard sometimes to get a good film of a really obese dog, like this dog was, on the right-hand side. And so you'll see how round, it's no longer egg-shaped, it's just plain round. And that is because it has pericardial fat. So everybody holds up a film and goes, oh my God, his heart is so big. Oh my God, his heart is so small. This is very controversial. A good rule of thumb is the shape of your patient will dictate the shape of your patient heart. Bulldogs will have rounder hearts. Greyhounds will have tall, skinny hearts, right? That's a good rule of thumb. There's a terrible estimate out there that says this. Dogs should have 3 to 3.5 times the width of an intercostal space as the size of their heart, and cats should have 2 to 3 times the width of an intercostal size space. The most accurate way, don't worry, we'll go through this, is the vertebral heart size scoring system. This measures the heart and width and height of the heart in comparison to the vertebrae. So here, we're going to do the vertebral heart size scoring system right now. So this is the best way. In a few films, I'm going to show you why that estimate, you shouldn't even be doing it. So here's a canine heart. We want to go ahead and, sorry, this is the estimated way. Sorry, I misspoke. It's not the vertebral heart size scoring system. So we said 3 to 3.5 times the width of an intercostal space. start from the front of one rib to the next front of the next rib. So that means the ribs have to be lined up correctly, right, in order to do this. So these are not too bad. They're not too off center or anything. So we look at 1, 2, 3, 3.5 times the width. Yes, this would be a normal canine heart. Let's get into the nitty gritty of the vertebral heart size scoring system. So you have to be able to see T4 through T12. This is a pretty decent film, but you don't want it rotated too much. This is an older cat. See how the heart has started to fall over a little bit. That's okay. But let's measure it out. So what you're going to do is you're going to measure the shortest and longest axis of the heart. So this way, and then transfer the measurement to the cranial aspect of T4. What the heck is she talking about? I didn't come up with this. This is actually derived from human medicine. A bunch of veterinarians figured out how it could be adapted. So here is our short way, because short is this way, right? Longer is going to be longer towards the heart. If we put it up at the top of T4, starting at the first rib, 1, 2, 3, 4, we get about 4.1 vertebrae in length. Just roll with me, people. Now, sorry, that's the long way. My goodness. No, that was the short way. Sorry, I cannot figure this out. Sorry, I can totally I'm going to go backtrack. All right, that's 3.2. I swear I created this film. 3.2 vertebrae. Some of you are like, Amy. If I had an audience, you guys would be like, you are wrong. You are blind. You're into your third lecture. You clearly need to just read the slides better a little bit more. All right, so 3.2. This is the short way, right? I've done this a million times. 3.2. All right, let's do the long way. Sorry about that, guys. All right, so 4.1. So here you go. 1, 2, 3, 4. You can now see there's 4 vertebrae. I could just count them. So you're going to add those up, all right? You're going to get 7.3 vertebrae. And what studies have shown is that dogs have under 10.7 is considered normal. Cats are under 8.7. It should account for 98% of the population. Now, boxers have normals as high as 12.6, and actually Cavalier King Charles Spaniels and Labs have normals as high as 11.7. So this is obviously going to be a little bit more scientific than just guessing. So we can also see the chambers of the heart. So on your left side, which is going to be their right chambers, and then remembering that your right side is going to be their left chambers. And on the top are the auricles, on the bottom are the ventricles. So it's kind of easy to remember, right? So A before V. Now on the VG, it's not so pretty. So we've got still right and left, cool. But we have like right atrium, aortic arch, then left auricle, then left ventricle, then left atrium, kind of in the middle there, then right ventricle. It's not as pretty, and then you can appreciate the pulmonary artery coming down there. All right, so let's talk about cardiac abnormals. Big thing that we always focus on. Oh, that heart looks so big, right? The left atrium enlargement is probably one of the most common enlargements we're going to appreciate on thoracic films. And most commonly, that's because it's going to be because of mitral valve disease. Rarely you will be able to detect right atrium enlargement on radiograph. So we're going to take a look at Tinker, 10-year-old female spayed Pomeranian, coughing, excessive panting. On physical exam, she has a heart rate of about 180. So she's very tachycardic, and she's got a murmur. And we take a film and we go, whoa, Tinker! My Lord, look at your heart. First of all, see the ribs? Now you're going to hear me say it a bunch because you're going to go back and you're going to appreciate it. So let's just do that rudimentary. Remember, heart this way has to be 3 to 3.5 times the width of the intercostal space. So go to the very front part of her heart towards your left. Now I want you to count width of intercostal space. 1, 2, 3. Yeah, about 3.5. No. So that's why we shouldn't just be guessing, and we should be doing the vertebral heart size scoring system. Now, in order to do that, we would have to rotate this dog probably a little bit better because she's very rotated in this. But let's take a look at what's really happening. When we put that clock face up, oh my goodness, do you see that bulge? That is not normal, right? And so essentially what we're looking at, mitral valve disease. And so you'll see that weird bulge coming out and that left area of the heart. We can also see generalized enlargement, like a basketball shape. So we think of pericardial effusion or generalized myocardial dysfunction. So egg-shaped heart on the bottom there. Not egg-shaped heart, but I want you to, now this one's a good film. It's not too shabby, a little rotated, not too shabby though. Count the number of spaces between the ribs. 1, 2, 3.5. This would be considered a normal heart size shape, right? Wrong, which is why vertebral heart size scoring system is so much better. I think everybody can probably just look at it and go, that's a big heart. It's missing its egg shaped. It's sitting at a 90 degree, not a 45 degree. It's not pretty looking. Here's that same dog. Pericardial fusion for sure. I mean, this heart's ginormous, right? Tracheal normals. You want to be sure to keep the neck straight when you are taking films. There's no normal size except for too small. We can see if it's displaced on a VD. It lies slightly to the right on VDs, but in the brachycephalic or obese pets, it lies a little bit more to the right than normal. So that 2 little lines there, that trachea, that's the trachea above there. Again, we don't worry about the size unless the animal can't breathe. And here it is on the VD, and this is where everybody goes, where, Amy? I have no idea. All right, so you have to remember your left is their right because they're facing this way, right? So your left is their right. You want to look on the right side of the animal. You can see the scapulas coming down. I'll help you out. Here it comes. There's the trachea, and you can actually filter once these little lines go away. Wait for it. Look at the trachea, and you can actually see the air branching off into the bronchioles. Cool stuff, kids, right? Tracheal abnormals. Primary tumors of the trachea is not really that common. Geriatric animals also get mineralization of the trachea. Size varies and really depends on the breed, but most commonly we're going to be dealing with tracheal collapse. So tracheal collapse is this loss of rigidity of the trachea. We want to look for it on lateral radiographs. And in a perfect world, we want to take both inspiratory and expiratory films. It usually occurs in obese dogs or toy breeds. It is hard to get these animals to stop breathing. They're dyspneic. They look like they're going to die. So don't hold their breath. Just do the best you can. Tracheal collapse. This is like sucking through the straw. And then unfortunately, we've got fluid in the chest cavity as well because this animal's not oxygenating appropriately. So you can just see that narrowing. That's not okay. So there's other mediastinal abnormalities such as a mediastinal shift, pneumomediastinum, mediastinal mass, and fluid. So the mediastinal shift is what it says. So if we have all the structures in the middle, then the structures get shifted from midline, right? So when this occurs because we have a decrease or an increase in the volume of one of the lungs. So in order to see a mediastinal shift, we're going to take a VD or a DV. The pneumomediastinum is where we get this free gas in the mediastinum. It causes an increased radiograph contrast. So remember, fat and air and fluid contrast things, and that's why we can see things in the body. When you all of a sudden you get excessive air in the mediastinum, it's going to contrast things differently. It can lead to a pneumothorax. Usually they're not dyspneic, but we can get air in the mediastinum from tracheal or esophageal tears, trauma, or jugular venipuncture or neck surgery. So take a look at this film. It looks wonky, but let's talk through it. We can see an intact diaphragm. Do you see an intact heart? Yes. It's a little rounder though than normal. It looks a little weird. The ribs are obviously split off from each other. So it's the dog's rotated. You can see the ribs above the spine, but you can see the aorta and the caudal vena cava in the caudal aspect of the chest, but look at the cranial aspect of the chest. You see the swirly lines where the yellow is, and then that red arrow is pointing to the cranial vena cava. So that's the vein. The same caudal vena cava is coming right through the heart. It's the cranial vena cava. You don't typically see that, but that air has actually contrasted it so you can see it. Mediastinal masses, you might actually see an elevation of the trachea in the cranial mediastinum on a lateral radiograph. It may be too difficult to determine if a mass is in the mediastinum or in the lungs itself. So we take a look. This is a hot mess film, right? But all we can really appreciate, it doesn't have a heart. There's really not a lot of lung field. Look at what the trachea is doing, right? This is why we want to try to keep the neck straight, because if we do see this bulge, it's going to clue us in. Same dog. So lung fields are actually equal. You can appreciate the fissure line. See that little line coming up there? That little fissure line. But that's a huge tumor sitting in the mediastinal area of the chest cavity. The esophagus, like I mentioned, it's not normally viewed radiographically. Most commonly, we see megaesophagus, and I'll show you that, and then foreign bodies. So megaesophagus. So look at the trachea here. Right below, if you go up towards the head of the animal, you see the trachea and how tiny it looks. I don't care. Remember, as long as the animal's oxygenating appropriately, I don't care. But the esophagus is pressing down on the trachea. It makes it look a little bit smaller. But what it really is doing is it's not really pressing down, but it's actually obscuring the trachea. So just keep that in mind. See how big the esophagus is. And then you see my little question marks there? Those are broken down costal cartilages. They are not tumors. They're not tumors. That's really key. And so people will go, oh my God, there's tumors in the chest. But that is just this. There used to be cartilage there from the rib cage connecting to the sternum. And it just broke down and it formed these like little nodules. This is a cat megaesophagus, which is of course owned by a veterinary technician. So I want you to see that little wonky weird line in there. Yeah, totally owned by a vet tech. And for that reason, right? All right, and then lastly, the extra thoracic stuff. This is the outside stuff. And so the outside stuff is the body wall, the spine, and the ribs. And we really don't want to overlook it. It is a good indicator of whether or not we took a good film. The ribs, we've talked about overlying each other, and they should be nice, crisp, and white. If we're dealing with gray or haziness, we might have motion or poor exposure. And when we evaluate the ribs, like in a trauma patient or we're looking for tumors, doing a VD or a DV is much better. Each side should be symmetrical. A radiologist told me that if you turn the film upside down or just flip it on your computer, see, again, sometimes I date myself. You know, one of the things that dates you, and you know, it doesn't matter how old or young you are. As you get older in life, for the young people, as you get older in life, you will start to say old people things. That's just a fact. So embrace it now that it's going to happen to you. Because in my younger years, I thought, no, I'm going to be cool until I die. I'm going to always know the things. The other thing that always ages me, which I will have such a hard time getting away, videotaping. That is not a word, people. Videotape. No one has tapes. Videotaping isn't a word. Recording is a word. That's the thing. But I always go, I'm going to videotape that. And everyone goes, I'm not even that old, but I say these things and I recognize I'm turning old. That's what's happening. So anyway, you can just rotate it on the computer. Flip the radiograph upside down on your computer, basically. It's easier to evaluate. I'm going to show you that. But most common, what we're seeing for injuries are trauma or cancer. And so in cancer, we look for decreased opacities, broken or fuzzy area. And we've already shown you an image of that mineralization of costal cartilages. This is why you flip the film. So on the right, your eye goes exactly to the heart, right? That small image, you dial in right to the heart. But on the left, now you can clearly look at each rib for anything that's broken. And case in point, on the film, that's how you normally view it. If you take a look, it is so freaking obvious on the right one, right? Broken, 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 broken on one on the right. They're all broken on the left. Obviously, that's the same dog. Everything's broken on the right film there. So spine and the sternum, they should be crisp and white in color. The spacing should be equal between the vertebrae, and spondylosis is common in our older animals, and certainly degeneration of the sternum is very common too. Now in brachycephalic breeds, particularly bulldogs, they can get this hemivertebrae. So if you ever see a triangular looking vertebrae, it literally looks triangular or wedge shaped and kind of wedged in between the other ones, that's a bulldog thing. It's totally normal. Primary or secondary cancers can occur, and those are usually seen as a lysis or proliferation of the vertebrae. And metastatic neoplasia occurs most commonly around the T3 vertebrae. This is mineralization of the costal cartilages. And if you look at that second line, that's the degeneration of the sternum. It's just breaking down. They're not broken, and we don't have to repair it. That's just normal old animal stuff. This is spondylosis, the bridging of the spine there. Very, very common. Again, it's not a fracture of the spine itself. It just means we've got arthritis. The animal's old and crunchy. And where I see a lot of this, if you've ever picked up an old cat and it kind of goes, meow, that's because we're probably pressing on all of that arthritis. What's wrong? Pretty obvious. And this is why we always check. This animal was euthanized before we ever took this film. But if you look at the back, yeah, pretty bad traumatic injury there. Yep. Oh, I don't know why I put an arrow there in case it was very obvious. Now it's very obvious. And then lastly, the diaphragm. So the diaphragm provides 50% of the respiratory force needed for inspiration. There's 3 openings through the diaphragm: the aortic hiatus, esophageal hiatus, and the caudal vena cava foramen. Your normal diaphragm obviously moves with the breath, but it should be crisp and white and intact. If you see an increased opacity, meaning it looks too white and you can't see that crisp white line, we think about lung tumors. Pleural effusion is obscuring it, or a hernia. And the two types of hernia we're going to talk about is the congenital, the PPDH hiatal, and the traumatic. So my favorite hernia in the whole world is the peritoneal pericardial diaphragmatic hernia. It's super fun to say. This is where your abdominal contents herniate up through your pericardial sac. So there's that sac that lives around the heart. Intestines will go up into the heart sac. Say what? And you may be living totally normal and not get detected until later in life. It's usually congenital. So this is an initial radiograph on a cat that was indoor-outdoor. And we take a look. It does look like the diaphragm's intact. There's not a lot of spacing between, but the heart, see how the ribs are not lined up? Yeah, soft's a little bit crooked. But you see how the heart's not sitting at a 45-degree angle. It looks a little bit enlarged. Took a VD. So this is intestines up into this. This is a congenital deformity on this cat where the intestines are living. And in fact, sometimes you can audibly hear digestive sounds in the chest cavity. That is really fun. So if the animal's having problems, which this one was having a little bit of a breathing issue, we go and take it to surgery because we certainly don't want intestines living up around the heart. Hiatal hernias, people get these all the time. This is where the stomach enters the chest cavity through the esophageal hiatus. Charpets are predisposed. It's generally congenital, but it can be traumatic. Usually it can be a clinically insignificant finding. So unless it's causing an issue, we probably don't do anything about it. Here's a hiatal hernia. So this was a very extreme case. You can appreciate how the stomach has very much entered the chest cavity. That is a hiatal hernia that definitely needs to be repaired. And here it is again. In fact, you can appreciate the mediastinal shift. See the displaced heart. And here is the stomach coming up through the esophagus and through that hiatal hernia area. That is definitely needs to be repaired. And then traumatic hernias, these are generally caused from vehicular or blunt trauma, bite wounds, penetrating wounds. But despite the severe nature of trauma, diaphragmatic hernias rarely occur. We see hit by car trauma patients all the time, and very rarely do we get one that develops a hernia. Most commonly, though, reported in this order, this is how herniated organs from trauma go in. So the liver goes up through the chest cavity first, followed by the small bowel, the stomach, the spleen, and the omentum, and the heart and the lungs can become displaced. Sometimes they get fluid buildup in their chest, which makes it difficult for you to actually diagnose the hernia. So this is Jingles, a domestic short-haired 1.5-year-old male neutered indoor out here, breathing funny, not eating, took a film. What? There's something going on. We take a film on the VD, and you can appreciate it's not just the stomach up there. We've got the loop of intestines. Part of the liver was up there. This cat probably got hit by a car. The owners had no idea. Came home, survived getting hit by a car, and obviously needed this repaired. So in conclusion, the ability to diagnose diseases relies heavily on the quality of the radiographs being taken. As a technician, you get to view it first. And certainly being able to identify normals from abnormals may save a patient's life. My beautiful children, all three of them. So there's my email address for you. Again, vetteamtraining@gmail.com, or my website. Reach out to me. I'm always happy to get back to you guys. I know that I wish I could be there in person. And before I completely sign off, I'm going to get a little sappy. Every single one of you are essential workers, and I know you guys know this. And 2021 for you guys has not started off very well. You were thrown a loop with the weather in the middle of a pandemic. It's just like, I know we're all burned out. We just keep going from one crisis to another, and when is it going to end? Here's what I want you guys to know. You are awesome, and I thank you all for doing what you do, because in the midst of this pandemic, animals, people's pets are the thing that has truly kept them going when they have felt so isolated. For so many people, they were severely isolated and feeling alone. And these lovely critters, like you see on your screen here, are the reasons that people kept smiling every day. And I know for me, that was very much true. And you guys are the ones to keep them safe and healthy and at home with their wonderful people owners, which is really amazing. So thank you for all that you do. And I'm happy to take any questions from here.
Hey, everyone.
Hello.
So we're here for any questions. If you have any, I'm here. You guys were quiet in the chat box, so tired. Didn't drink your coffee yet, so.
And I am monitoring that chat for you so I can let you know if anyone chimes in.
Thanks, TC. I appreciate that. I'm glad you enjoyed it. And if you guys are shy and you want to email me, I think I threw my email address up in the chat box, but you saw at the end of every single presentation, I'll throw it up there again in case you ever need to reach out to me for anything. There it is. Hopefully one day we'll have veterinary conferences in person next year. Please let it happen. We're all done with this stuff, myself included, so.
It's getting there.
Yep, getting there. I feel like there's a little bit of hope, which is really good. So
We're on the come up, hopefully.
Oh yeah. What dose for pred and prednisolone? Great question. You know, I am not a veterinarian, so I would have to check with my internist. It's escaping me right now. I would have to check with them and see what they're really wanting to do or start the pet on. If you want, email me at that email address and I'll let you know what my internists usually recommend to start with and then go from there. So yeah, apologies that I can't think of it. I have a dose in my head. I just don't want to say it. It might be right. It might be wrong. So yeah, definitely reach out to me. I'll make sure that I get you the correct dose on that. Any other questions? Hopefully this was of interest to you guys. This is hard for me as a presenter. I like to be there and engage you guys, and I hope that you had some fun. The nice thing is you could sit home in your pajamas, which is really nice, right? It does cut down on having to get dressed up. And oh, you know, the other great thing about online conferences is that you don't have to fight to get to the bathroom. So in every conference, because it's a lot of women, we always have to fight to get to the bathroom. So now we can just stay home, which is, it's true that that's one of the few perks. You just go use your own facility.
Oh, it's always a nightmare.
Right? It is. It really is. So yeah, absolutely. I think that's it for questions. So
that's all I'm seeing for now.
Yeah. Do you have any closing things you need to do?
All right. Well, I guess, yes. So if there's no more questions, Amy Newfield sent vetteamtraining@gmail.com. You guys can feel free to email her at any point. But thank you so much, Amy, for coming. And thank you guys for being here. And that will be the end of the session today.